Cik Syam. Cik Syam. Cik Syam. Cik Syam ada ke? Cik Azrul. Cik Azrul. Ya, tengah kau. Okay. Itulah satu. Perhiasan. Kau foto kat ni. Syam. Cik Syam.
Ya, saya.
Ni dah boleh broadcast dah lepas suku.
Ni nak broadcast?
Ya.
Mana slide? Kau nak pancarkan? Tak pancarkan? Atas sikit. Atas sikit. Deh. Okey. Saya minta kenalan untuk broadcast semua. Okey. Dengan lafaz bismillah.
Recording in progress.
I'm at home. I've got kids around. Anytime they'll be popping in. Hopefully we get this done, inshallah. Bismillahirrahmanirrahim. Distinguished presenters, fellow researchers, and all participants, ladies and gentlemen, I greet you with the warm greetings of peace. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Peace be upon you. I am Dr. Luqman, and on behalf of the organizing committee, we wish to extend our warm welcome to all participants to this year's symposium, Healthcare and Research in the Pandemic Era. This is in conjunction with the 23rd Medicine and Health Research Week. Now we have a very exciting lineup for you today, and without further ado, we would like to invite our first speaker for today, the Associate Professor, Dr. Nick Ruziani Nick Jafar. Our esteemed speaker is an Associate Professor in Psychiatry and a Consultant Psychiatrist here at the Faculty of Medicine. Her area of interest include lifestyle factors and severe mental illness, mood and anxiety disorders, and provides consultation liaison psychiatry on disordered eating, obesity, and metabolic disorders. A lecturer for today is providing psychological support to healthcare workers during the COVID-19 pandemic. Without further ado, please welcome Dr. Nick Ruziani to deliver her presentation. Thank you.
Assalamualaikum, Dr. Luqman. Thank you so much for that kind introduction. Now, allow me to share my screen, yeah? Agak pula. Okay, anyway, sorry for that slight delay there. So I would like to thank you to the organizer for inviting me to share our very own experience as a Department of Psychiatry in providing psychological support to the healthcare workers during the COVID-19 pandemic, but focusing on the first phase of MCO. So we'll be sharing our experience then, yeah. Now I'm just focusing on two parts. That is the vulnerability of the healthcare workers to psychological distress and the factors that would be contributing to it, and what we did during the first phase. Now, we know for sure that since the beginning of COVID-19 pandemic, that healthcare workers have showed remarkable resilience, manning the whole pandemic thing, despite the increased risk of being infected. There was very real fear of being infected, of getting infected and infecting others. This is one of the largest registry-based cohort studies in Scotland. They found that this fear is real. Healthcare workers are at highest risk as compared to other essential workers, and particularly those healthcare workers who were facing patients. They were 3 times more likely to be admitted with COVID-19, particularly in unsuspected patients, and the risk from the risk of getting infected from colleagues as well, particularly in the first 3 months of the pandemic, and the risk doubled for them to infect household members for the front-facing healthcare workers. So at the same time, it is a double-edged sword being healthcare workers, as we know that as they were applauded as heroes, we also noted that there was an emerging stigma against healthcare workers. I'm sure many of you have heard anecdotes like, healthcare workers not allowed to enter their own house, not after certain procedure being done to make sure they are all clean. Yes, so this is real. And you can see here, studies have shown that this stigma against healthcare workers has become widespread, under-recognized, and in particularly it's associated with what's termed as COVID stress syndrome. This COVID stress syndrome is anything that is basically encompass pandemic-related phenomenon which includes the fear and avoidance of healthcare workers. So definitely this has put healthcare workers at greater risk of getting psychological distress. Yeah? So healthcare workers are the most vulnerable groups at risk of mental health issues. And in particular, the fear of the unknown. I think we have been hearing this again and again. The uncertainties. Yeah. So the fear is at the top of the mental challenges. And in particular, the added perceived stigma from their own family members as well as the society heighten the negativity and resulting to in stress as well as isolation. So what we did, we also had our own study on health anxiety. The study showed the study actually looking at the health anxiety that is defined as anxiety due to perceived threat to one's own health, which range from the absence of health awareness itself to illness anxiety disorder. Now, illness anxiety disorder is a new term for what we used to know as hypochondriacal illness. So from the study, we determined the health anxiety score and how it correlates with what we perceive as our risk of getting infected, the knowledge, attitude, and practice of healthcare workers. So this was done online at the very beginning of the MCO. I think we started blasting it on the 18th March itself when the government announced the MCO. Yeah? So it was a cross-sectional survey done over 700 healthcare workers. And looking at it, we found that interestingly, the source of information, whether you get it from the social media, from the radio, from the TV, actually has some association with how you perceive your risk of getting infected, as well as it also influences your knowledge, your attitude, and your practice scores. And it also showed that the higher perceived risk for COVID-19 significantly predicted higher health anxiety scores, yeah, the more and higher cautious attitude towards COVID-19 also significantly predicted the higher health anxiety scores. So potentially how we manage the sources of information, particularly at the beginning of the pandemic, where there's so many uncertainties at that time, is very important to determine, to influence the anxiety. We also did we also analyzed some preliminary data looking at our own healthcare workers, the most troubling or the psychological symptom, that is the suicidality. Yeah? So we found that about 11.1% harbors the current suicidal ideation, and about 10%, 9.9% had clinical depression at that time. And the risk factors that were associated with the current suicidal ideation is having the depression itself during that time. And even mild depression is associated with the presence of current suicidal ideation. And also interestingly, those who had been working for quite a while, over 10 years, apparently quite resilient to this. Now, there is a need to provide prompt psychological support to healthcare workers during this time. So just going to describe what were provided at the time. There were 4 types of channels that were set up in such a short time so that psychological help would be within reach, as well as later on we did set up some outreach programs so that when we think that this perhaps is also of advantage to our healthcare workers. So we immediately set up the website, which was dedicated to the hospital staff. So we look at this. This is our website called www.tabah.my. This is where all the important information, particularly focusing on the psychological support, so that we provide access to help. Yeah, so we have general information and link to that is important. Also provided at the website. this is in particular linkage towards the psychological first aid, for example, hotlines, as well as provided linkage to other channels of information, Telegram, and during this time, one of the issues were about childcare, as healthcare workers need to work, and the children had to be kept at home. So this is one of the issues. So one of the link is also provided there to help with that, and of course the tabung prihatin COVID-19. Yeah. So at the same time, we were working hard providing or developing an electronic booklet on psychological support, in which it's so downloadable, and in which there is a lot of simple relaxation techniques, stress management for self, and all the self-care skills that can be easily accessed. Now, this is the Telegram that was set up so that you get same information as well. Okay, hotline was also set up. This is e-posters that were distributed throughout the hospital. Now, one of the first steps before we actually can set up the hotline, for example, we need to set up our very own psychological first aid team. Yeah, so while we do not start from the page zero, because we do derive experience from providing psychological first aid during disasters. At the same time, COVID-19 pandemic also was rather unprecedented in many ways. So so we do have to have some refresher course, at the same time modifying how we're gonna actually deliver it. Yeah, so we had a very brief course, and the team consists of psychiatrists, medical officers, all the clinical psychologists that were available, and the counselors then who were put on roster to man the so-called the hotline. Yeah. So who actually called? Yeah, during this is how many people actually reach out, and what kind of problems during the initial phase of MCO? Mostly the inquiries were regarding the technical issues, the definitions of who the PUI, what to do, and basically the informations that should be that were actually provided by the Bilik Gerakan at the time. So we do link them, all these queries, to Bilik Gerakan, and we do also receive calls from public members, even though this hotline is actually manned or dedicated to our own healthcare staffs. Yeah, so they were listened to, redirected to other helplines that were already available. For example, Mercy Hotline. We also had calls from our very own existing psychiatric patients, yeah, because some of the appointments were actually deferred due to the MCO at that time. So they were also listened to. The urgent calls were later linked to the psychiatric clinic for further assistance, yeah. And the calls were also screened, and there were and those who need further referral to be seen by the psychiatric medical officers and psychiatrists themselves were then referred to. So at the same time, so we also developed our own outreach programs. Now, so we work with the Bilik Gerakan, who provided us with those who were in quarantine, and those patients, not patients, sorry, they were the healthcare workers who were, for example, the person under investigations, as well as those who were infected with COVID-19. So the volunteers from the Department of Psychiatry would call up the affected person and provided the psychological first aid via phone calls as well as video calls. So there were some teams that emerged from the person under from the PUIs, yeah, the responses. Many of them welcomed the calls, There were a lot of anxiety regarding pending results at that time. Many actually expressed stress from being quarantined in the hostel, away from the family members, missing their children. Some of them actually sent their children away to their parents and had not seen the children. I remember one of the PUI actually were breastfeeding at that time and had to wean off because of this. Of course, it caused a lot of stress and anxiety and depression as well. So they were worried over other family members who were also in quarantine. They were worried about their own medical problems that were deferred in the appointment, worried about pending workload because they also, while in quarantine, they were also receiving calls from their superiors about the work that were waiting for them when they return to work, worried about being infected again upon coming back to work, still worried about family members, as I mentioned earlier. Some even worried about the elective treatment, which was postponed due to the quarantine, adjusting to working from home regime after the quarantine, fear of receiving phone call from the hospital line, and so on. Yes, so these are the things. So they were also giving feedback to us regarding what they think that would be helpful. So they said they actually get good support and receiving help also financially, and they felt like some of the information were not transparent, especially with regard to the result, and that caused more anxiety. And they have actually set up their own WhatsApp group and would like to have counselors in this as well to provide immediate support. Okay, that is the program, the reach out program, the first one, yeah, where we targeted only the PUIs and those who were infected. For our second reach out program was targeted towards healthcare workers who were working at bilik gerakan as well as emergency department. So what we did is we offered this relaxation skill sessions, teaching simple mindfulness about twice a week, just 15 minutes. Couldn't be too long because they were not to disrupt with their work. So we went there, a team of us from Department of Psychiatry went there. It's reported here, and there are some pictures. We were doing some mindfulness, taking a break from the work. Sometime, I think usually we went at 4 o'clock, and this is more service focused rather than research focused. But we did have a bit of a preliminary data where we actually asked them to complete some psychological distress score as well as mindfulness score. So not managed to fill up, but because that was not the main focus for them to fill up the question, is whoever fill up, we welcome them. So we did find that they have a significant reduction with regard to mindfulness, meaning that they have better awareness, better presence with these exercises. Yeah, as you can see, the MAAS score with the pre-test and post-test that was done. Can't remember how many weeks after. Yeah. So another innovative technology or intervention that was developed was this chatbot. Yeah, it was in early May 2020. It was soft launch at that time, where there was this a chatbot application known as IRIS, or short for Illness Recovery and Self-Management. Yeah, so this is basically guides users. This is not only open to the healthcare workers, but also to the public. So it guides the users through a series of questions to identify their needs and provides the audiovisual guide in form of relaxation technique, mindfulness, sleep hygiene, and so on. That is available and still available now. Okay, I think this is my last slide. And before I end the talk, I would like to thank my Department of Psychiatry as well for this. Okay, for allowing me to share with the rest of the faculty as well. Thank you.
Thank you very much, Dr. Ruziani. We only have like a minute or two, so
Yeah.
I'll open up any questions on the Q&A. Oh, yep, we got one.
I will stop the slides now, yeah?
Right, sure. There's an anonymous attendee here. Excellent effort, Psychiatry Department. May I know who managed the hotline?
Okay, previously it was manned by our clinical, a team, as I mentioned earlier. They have a roster, but now it's headed by our counselor, Cik Zakwan.
All right, so is there another one? So that's it, yep.
Yeah. Okay.
So,
Thank you very
much. Thank you very much, Dr. Ruziani. So,
my pleasure.
I'm going to move to the next speaker of the day. I would like to welcome the next speaker, Associate Professor Dr. Sawal Hamid Muhammad Ali. He is an engineer from the Department of Electrical, Electronic and System Engineering. His work focuses on embedded system design, or IoT, and is a Master of System Development. He has co-developed embedded systems for many different applications. Now, without further ado, please welcome Dr. Sawal Hamid and his presentation on GPS-based tracking and monitoring application for high-risk COVID-19 patients. Please, welcome to the floor.
Thank you, Dr. Muhammad Luman. Thank you for the introduction, for the nice introduction. Let me share my screen. Sorry. One second, yeah. Okay, I'm having a problem with it. Okay.
Take your time, no problem, no problem.
Okay, can you see my screen now?
Not yet. It says here you start. Okay. Yeah.
Is it okay enough?
There's a bit of a there's a huge box over there, so I'm not sure what it is, but yeah. But we can see like 90% of the screen. Maybe there's a widget over there. Okay. But will it affect your talk? If it's not, then we can just proceed, no problem.
No, on my screen it seems to be okay, but
Prof, minta maaf.
yeah.
Okay, Prof, boleh tak Prof tutup yang video, tepi tu Prof ada video kan? Bukan video, maksudnya gambar-gambar panelis.
Panelis, ya, betul.
Klik satu je ataupun nama je.
Sekejap
Waktu dia nampak gambar tadi.
How about now?
Belum.
Belum Mesti ada
Okay.
Okay, alright.
Cantik.
Assalamualaikum and very good morning everyone. Okay, I'm Sawal Hamid bin Muhammad Ali from the Faculty of Engineering and Built Environment. Okay, my topic for today is GPS-based tracking and monitoring application for high-risk COVID-19 patients. Okay, hold on. Okay, so these are the research team members for this particular project. Okay, me myself from the Faculty of Engineering. We have Prof. Dr. Nurfiza Muhammad Mota from Faculty of Medicine, Prof. Dr. Rosrina. I think sorry, Prof. Dr. Nurfiza Mota from the Faculty of Medicine, Prof. Dr. Rosrina Madumana from Faculty of Medicine, Associate Professor Dr. Patrick from Faculty of Medicine, Dr. Najma from Faculty of Medicine, Prof. Dr. Raja Effendi from Faculty of Medicine, Associate Prof. Dr. Muhammad Shahrul from Faculty of Science, and Dr. Ahmad Subhi from Faculty of Medicine. So as you can see that we are, the team members come from different kind of faculties. Yeah. Okay, so I think if we still remember last year, I think during the early time of the pandemic, okay, there were a lot of applications that were developed for related to the COVID-19. Okay, I think that we still remember about Gerak UKM that was developed last year as well. For the people, so for those who want to travel, okay, they can use Gerak UKM to register where they are going and so on. And then I believe you still remember, okay, we still have like a check-in. MySejahtera is one of the example using the check-in method where you have to check in everywhere that you go. You have to scan the QR code, okay, to record your presence at that particular premise. And then we also have application that can also give a lot of information and news about the COVID-19. On, for example, on your MySejahtera, now you can look at the number of cases, number of daily cases, and any other information that the Ministry of Health want to convey or want to pass on to the people. Okay, you can use the MySejahtera app to know some of the information or news, right? And other than that, there are also applications for the contact tracking. Okay, MySejahtera is one example of contact tracking, but it is based on the check-in method where you have to check in wherever you are going, so that at the end of the day, if you are tested positive, the Ministry of Health can open up your records or your log, so that they will find out where you have been during the last 14 days, so that they can notify those people in that area. Okay, so other than check-in method, there is also a method for contact tracking using the GPS sensor, GPS of your mobile phone, or a Bluetooth sensor. Okay, I will start my talk with the GPS sensor based version, because that is what we were doing in the beginning, but later on we changed to Bluetooth based contact tracking. Basically, at that time, if you still remember, around March 2020, okay, Malaysia, we still lack the tool to trace the individuals, to trace the contact, okay. So it is very essential to trace or to locate, okay, the high-risk individual, so that we would know where they have been and we can notify the people in that area. Okay, I believe MySejahtera will also introduce around March 2020. And the objective of this research, of course, first is to implement the assessment framework. Basically, this is the one that you can see on MySejahtera, where if you remember, when you switch on the MySejahtera, you have to key in your profile, where you have to answer some questions. Okay, I believe about 10 survey questions. And from the answers given to that questions, MySejahtera will tell whether you are low risk or high risk, okay, whether you are green, whether you are blue box or red box, and so on. Okay, so basically this is the same thing that we are doing with this particular application. We have the questionnaires or surveys, about 10 questions for you to answer, and then from that we will assign a score. Okay, based on the score, we will stratify the individual into high, medium, or low risk. Okay, and in this project we are also developing the application, the smartphone application, but this is not similar like MySejahtera, but we are using GPS sensor, and at the same time we also develop a dashboard system for the authorities. For example, for the Ministry of Health, if they want to monitor your locations, so that those who are infected, they will know where they have been. So it's very easy to control. Let's say if they are, they can follow the orders of movement control orders. So this is something that we provide to the authorities. Yeah. So example, okay, this is one of the example from the application. Okay, by the way, the name of the application is COVID Sense. Okay, we name it as a COVID Sense. Okay, so the self-screening test is similar like the MySejahtera, where you have to answer some questions. Okay, from the answer, risk score will be given, and then the application will also can report. Can produce a report where you can submit the report, or you can send the report to share the report with anybody. For example, let's say if you are going to your office, let's say if your boss want to know whether the risk level of your symptoms and so on, so you can share the report to them. And at the same time, if you are high risk, let's say you have been you have few symptoms and then you are considered as high risk, so the application will give the hotline contact for you to contact directly to the healthcare services. Okay, and then from that question, as I said, okay, for example, this is one of the questions. Do you have cough? Yes or no? Okay, basically you have 12 questions and you have to answer. Okay, from the answers, the score will be given, and based on the score, you will be stratified into high, medium, or low risk. Okay, if you don't have low risk, if you have no risk, then the app will tell you you have no risk. Okay, and then if you look at this screen, you can see that on the left side is the application name, COVID Sense, okay, with the UKM logo at the bottom. And then on the right side is the dashboard, where this is the dashboard that let's say, for example, if we provide to Ministry of Health, they can use this dashboard to monitor the location of those people. Okay, you can see that here, I think during the study, okay, we collected data from 50 subjects. Okay, so those are the locations. Those are the locations of the subject. Some of them. Okay, here in this application, your name is not needed. I mean, it's not compulsory for you to key in your name. You can also log in or register as anonymous. Right, so that some people, because we don't want to collect your personal information, but if you are willing to share your personal information, for example, your phone number, etc., then you can key in. Okay, and then if you move from one place to another place, okay, the app will continuously track your position. Okay, if you move between 1 kilometer, more than 1 kilometer, the app will lock your location so that we will know whether you are moving or not. Yeah. Anyway, there's also another problem when we talk about the application. Okay, when we talk about the application for COVID-19, okay, the thing that we have to find is the adoption rate. Okay, in the beginning, I believe the adoption rate for this kind of application is very low. Okay, I think maybe you can also remember in the beginning, not many people want to install even MySejahtera, but when they impose where you have to log in, check in, wherever you go, so that if not, you will be, you'll be fined for not checking in. So then people start to install MySejahtera, and then for the vaccination, where you have to install MySejahtera, okay, because of that, people start to install MySejahtera. Okay, so other than that, there are a few other problems. For example, lack of integration. Okay, we have different kind of applications for Gerak UKM, for MySejahtera. If you want to travel, you have another application. There are different kind of applications, but so they are doing different kind of things. So at this time, we were thinking that it's good to have only one application that we integrate all the features together into one application so that people don't have to install so many applications. Okay, and then there's another issue with this type, with the GPS-based application. Okay, as you know that privacy issue is one of the concern. Okay, people are still skeptical. There's a stigma that if your location is known, okay, so we think that our privacy is breached. Okay, so because of that, we have switched, okay, from GPS-based tracking into a Bluetooth-based contact tracking. Right. So with Bluetooth-based contact tracking, okay, we will not record your location. Okay, the phone will communicate with another phone if they are in close proximity. Okay, for example, if you are talking to someone, let's say if you have been in the distance less than 2 meters with your friend, okay, obviously they have your friend need to also install the same app. Okay, so the phone will exchange the ID. Okay, the phone ID will be exchanged. If you are in close contact, less than 2 meters, for more than 10 minutes, okay, the phone will exchange the Bluetooth ID or the phone ID. So the phone will keep all these records, all the phone IDs that you are in contact with for the last 14 days, okay, because we store the record for only the 14 days. After the 15 days, the first record will be removed, then you will have another 14 days record. So in one time, your phone will only keep this 14 days record. Yeah. So if you are tested positive, let's say if you are tested positive, now all the data is only stored on your phone. Okay, it's only stored on your phone. Nobody knows where you are. Nobody knows who you are, and so on. But if you are tested positive, then you can give consent for the authority to download all the logs from the phone. So that with that, so when you upload that log of the contact to the server, okay, the server can automatically notify all the users stored in that log. Okay, for example, you've been in contact with 10 people. Okay? All these 10 people will get the notification that they are in contact with the positive cases. So they are advised to go for this for test for COVID-19 testing. So in this way, we are thinking that through this Bluetooth tracking, okay, we are protecting the privacy of the users because everything is stored only on your phone. Nobody knows who you are, and the notification is done by the system itself. Nobody will know. Okay. So, and we add in some other features like a heat map, where with the heat map, the number of cases will be known so that you will know whether you are living in the red zone or green zone or the yellow zone, okay, automatically, because this is updated every day, daily, because as you know that Ministry of Health, they report the number of cases according to the areas daily, right? So we will update this location daily so that you will know whether you are living in that kind of particular area or not. And we add also another features for airborne transmission because we also include the particulate matter, the PM concentration in your area, so that if you are living in the area with a high concentration of PM, okay, as you know that there's a possibility for these particulate matters to carry the virus, so you will be advised to limit your outdoor activities. Okay, so this is the COVID Sense 3.0 after we changed from GPS into the Bluetooth tracking based. Okay, so these are all the features included in the application. Okay, the contact tracing, the heat map, the travel permit, the self-screening test. You have information including the airborne transmission. So here is what this is what we meant. We try to integrate all the features into one single application. Okay, and at the same time maintain the user privacy. Okay, and these are the timeline that we developed the application. Okay, we started with COVID Sense 1.0. This is based on GPS tracking. As mentioned earlier, you don't have to key in your name, but your record will be stored on the server, on the dashboard anonymously. The Ministry of Health can monitor your location. But with COVID Sense 2.0, we remove the data sending to the server automatically. We store all the information just on your phone so that people will not know where you are unless if you are tested positive. And then with COVID Sense 3.0, we change from GPS into Bluetooth. Okay, we use the Bluetooth as I mentioned earlier, how we use the Bluetooth to track. With Bluetooth is much better compared to GPS because this is individual. Okay, so you will know if you are in contact with that particular person. If you think like MySejahtera, if you check in to let's say if you go to Tesco, okay, you check in and you are tested positive, so they have to notify the 3 people that have been to Tesco. Okay, let's say all the people that have been to Tesco in that particular time, you have to go to do your checking because you never know whether you are in contact with that particular person or not. Okay, but you are in the same building with one of these positive case. Okay, but with Bluetooth is better because it's 1-to-1. And then with COVID Sense 4.0, we add the airborne transmission. So if this is the screenshot of the COVID Sense, if I don't know if you can see my screen, you can see the app. I'm on my phone here. You can see the application. Can you see or not? Can you see my phone?
Boleh nampak.
So I think you can see that this is the COVID Sense 3.0. Whenever you switch on the app, okay, the app will do everything in the background. You don't have to do you have to do nothing. Okay, you just have to use your phone like normal, but the phone will keep exchanging the phone ID with your close contact. Okay, and if you are tested positive, you can choose to click tested. If you click tested positive button, and you have to answer whether you have tested positive, you have to key in the time, and then when you click report, the phone will send the log file to the server, and the server will automatically notify all the people that you are in contact with. Okay, so I believe this is a truly privacy protected application. You don't have to do anything. You don't have to check in. You don't have to scan the QR code. The phone will do everything for you. And the app was featured in Bernama News on 23rd April 2020. Okay, And then also this also was picked up by several other major news portal. Yeah. Okay, I think that's my last slide. Yes, thank you very much. So I will open the floor for any questions. Let me stop.
Thank you. Thank you very much, Professor Dr. Shawal. I mean, this is a very splendid piece of technology, and I'm surprised myself that I didn't get to know about this until today. So yeah, we still have a minute or two to actually go with the question and answer. But at the moment, tak ada lagi. So I would like to ask you one question. What is the major challenge lah for it to be applied or macam diintegratekan dengan MySejahtera? Because I think, again, I know there are people yang memang tak akan ambil install MySejahtera and whatnot, but at least it can be implemented for people yang macam dalam specific niche of working area, macam dalam hilang and all that again, so it's easier for us to look into that. And why is it not been macam kita tahu benda ni dari sudut it apply dalam banyak, at least kalau not for the whole country, but at least macam in states like Selangor or whatnot. Do you have any idea on that?
Okay. One thing that we have to understand for a COVID-19 application, okay, you cannot publish the app. Third party cannot publish the app to the Play Store, Apple Play Store or Google Play Store or Apple App Store. Right. Apple and Google will not allow third party to publish any COVID-19 related application. Only the authority can publish. Okay. Actually, last year, during April, we did together, me and Prof. Dr. Nolfiza, we met with YBKJ. Actually, we have presented the COVID Sense application. We were willing to give the application for free to the government, but at that time, I believe that they already have MySejahtera. And though we tried to convince them that this is better than MySejahtera more or less, because this is like a Bluetooth contact tracing, it's very individual, so it's very easy to trace and so on. But I think because they already have MySejahtera, maybe they don't have plan to change to any other app. So without the endorsement by the authority, we cannot publish. So when we can publish it, people cannot use. So for the study, we provide the app. We did a closed beta, closed testing, where we provide the individual application to these people. We provide the application and we ask them to install for us to test. That's all that we can do. Yeah.
Right. Okay, that's good. All right. Thank you very much, Professor, for the presentation. I really appreciate that. So now I'm going to move on to the next presenter of the day. I would like to invite to the screen Professor Dr. Salina Hussein. Okay. Our speaker here is an esteemed professor of rhinology and a consultant otorhinolaryngology that specializes in nose and skull-based surgery and has special interest in allergy, smell, and taste. Her presentation for today is the association of olfactory impairment with RNA viral load in COVID-19 patients. Please welcome to the screen Professor to deliver her talk. Yeah.
Thank you very much, Dr. Muhammad Luqman, for your kind introduction. It's basically my talk is pre-recorded because I'm worried there will be internet connection. I think Encik Muhammad Khaidir can share the presentation.
All right, sure, no problem. We'll wait for Encik Khaidir to bring up the video on the screen. Yeah.
Assalamualaikum and good morning, ladies and gentlemen. Today, I will share with you our research on COVID-19 patients. We studied the association between olfactory impairment and RNA viral loads. This research involved multidisciplinary teams that involve a medical department, microbiology department, and so on, and also involve MAEP COVID centers in Serdang. I would like to express my deepest thanks to our faculty for giving us the COVID-19 grant of 30,000 Malaysian ringgit to conduct this research. We managed to produce 5 manuscripts. Half of it have been accepted for publication, and the other half are still under journal peer review. Severe acute respiratory syndrome, coronavirus 2, also known as COVID-19, became a global health pandemic since 11 March 2020. Common presenting symptoms were fever, sore throat, myalgia, and shortness of breath. The following month, that is in April 2020, the Center of Disease Control and Prevention in the United States has considered the loss of smell and taste as valid COVID-19 symptoms, which may be present up to 2 weeks of infectivity. There have been many postulations of the mechanism of olfactory impairment in COVID-19 patients. The first one is a direct damage to the olfactory neuron. It is due to the binding of the COVID-19 virus to the olfactory receptors. Number 2 is invasion of the virus to the olfactory bulb through the cribriform plate. And number 3 is COVID-19 virus causes inflammation of the olfactory mucosa, leading to damage of the olfactory nerves. And lastly, it may be due to the viral infection causes mucosa inflammation, and this acts as a barrier to odor in penetrating the olfactory receptors. The overall prevalence of olfactory impairment in COVID-19 patients was about 48%. One of the recent olfactory surveys in COVID-19 patients found that olfactory dysfunction was about 86%. However, there are scarcity of data on the olfactory impairment in COVID-19 patients that was assessed objectively using smell tests. Majority of studies evaluated the olfactory impairment subjectively using questionnaires. There are few smell tests available in Europe and US for objective evaluation of smell, such as sniffing stick smell test, APSIT, CCSIT, and CCRC. We used a culturally adapted Malaysian version of sniffing sticks smell test, smell identification test as our assessment tool. We recruited all patients who had PCR positive to COVID-19. The symptoms were assessed subjectively using MSTQ questionnaire and objectively using smell test. In COVID-19 patients, we adhered strictly to the protocol of using full PPE during the assessment. The odor is presented 2 centimeters in front of the nostril for 2 seconds. The patient has to choose the picture representing the odor in the chart. The demographic data, nasal symptoms, comorbidities, duration of admission, duration of symptoms, and RNA viral load results were recorded. We look into the association between baseline characteristics like age, number of days from the diagnosis to smell test, and comorbidities among the smell group. That means among the normosmic patient, hyposmic patient, and anosmic patients. We found that there were no significant association between age and smells group with p-value of 0.42, as well as no association between comorbidities with smell group. However, there was association between the day from the diagnosis to test with smell groups with a p-value of 0.02. There was no correlation between the smell score and age. However, there was a significant negative correlation between the smell score and duration in days from the diagnosis to smell test with a p-value of 0.04. We use a candle 12B to analyze the association between the subjective and objective assessment. However, the result was not statistically significant. We found that there was no correlation between RNA viral load and a smell group with a p-value of 0.38. And there was no significant correlation between olfactory impairment and RNA viral load with p-value of 0.61. Olfactory impairment may occur prior, concomitantly, or after the development of COVID-19 symptoms with a median onset of 3 to 4 days and persist for 7 to 14 days. We performed the smell test within 2 weeks of diagnosis. The analysis showed a statistically significant between smell groups and date the smell test performed from the date of the diagnosis. We found that 98.8% of COVID-19 patients did not complain of smell loss. However, 77.4% had loss of smell detected on sniffing stick smell test. There was a negative correlation between the smell test score and duration of smell test performed from the date of the diagnosis with a p-value of 0.04. This suggests that smell progressively worsened within the first 2 weeks of diagnosis. Wolfall et al. Found that the highest pharyngeal viral load was during the first week of infection with a peak at day 4 of infection. Furthermore, they found that half of their patients had seroconversion occurred after 7 days and 14 days in all patients with no reduction in viral loads. In our study, the smell test was performed up to 2 weeks of diagnosis. The result was not significant, maybe because of the test was performed after 7 days and majority of patients had seroconversion with no reduction of viral load. Hoffman stated that olfactory impairment may be due to pathogenesis involving the olfactory nerve. Viral load samples were taken from nasopharyngeal and oropharyngeal areas, and these may not be a representation of viral loads within the nasal cavity. Zhu et al. Discovered that viral loads were higher within the nasal cavity compared to the oropharyngeal region. In our study, viral load samples were taken from nasopharyngeal and oropharyngeal region. This may explain why there is no statistical correlation between olfactory impairment and RNA viral load. This picture to show you the location of olfactory nerve. It is situated in the roof of the nasal cavity. And this is the second picture to show where we take the pharyngeal swab, one in the nasopharynx and the other one in the oropharynx. So the location of this area is quite far from the location of the olfactory nerve. Early diagnosis in patient with anosmia or hyposmia who has close contact with COVID-19 patient is crucial. This is necessary to reduce the spread of COVID-19 and control of the pandemic. Patients with new onset of olfactory impairment should be isolated and tested for possibility of COVID-19 infectivity. This is because COVID-19 patients may be asymptomatic or anosmia may be their only symptoms. A meta-analysis by Acknowledgements et al. Discovered that the prevalence of COVID-19 was higher when smell loss was assessed objectively, hitting a more accurate reporting. 77.4% of our asymptomatic COVID-19 patients had olfactory impairment on sniffing stick smell test. Therefore, the assessment and evaluation of olfactory function is crucial in patients with COVID-19 infection, despite negative of self-reporting symptoms. Although there was no correlation between olfactory impairment and RNA viral loads of nasopharyngeal and oropharyngeal swabs, subclinical olfactory impairment may be the only symptom of COVID-19 unrecognized by patients. The message that I would like to convey is that majority of asymptomatic COVID-19 patients didn't realize that they have olfactory impairment, and it was detected when we assessed them using a smell test. Therefore, the objective smell test may be useful in as a screening tool for COVID-19 patients. There was no correlation between olfactory impairment and nasopharyngeal and oropharyngeal RNA viral loads. I would like to acknowledge all my medical officers, lecturers, and all staff of ENT, UKM staff, and MAET staff for supporting me in this study. This is my reference. With that, I would like to thank all of you for your kind attention.
Thank you very much for the presentation. It was very informative. I'm sure we have a bit of a time here. We have one question in the Q&A box. This is from an anonymous attendee. He or she have asked, could the significance be related to the sample size of each group? So I'm guessing, was there a sample size difference from the ones that the study that you professor have conducted and the papers that are being reported? Was that the case?
Yeah, thank you for the question. Basically, the sample size that we calculate is for olfactory impairment and viral load. So we had about 89 samples. 89 samples. Basically, we have two cohorts of patients. For the subclinical olfactory impairment, we have a different cohort of patients, and for the viral load and olfactory impairment, different cohort of patients. So altogether, it's basically we have about 160 patients. So I think is because we don't subcategory into normosmic, hyposmic, and anosmic. So we just compile for the whole patient who has olfactory impairment. So I think the study is still within the power.
Right. So this is like a general question for me. I'm a novice in this, so pardon me. So would you expect to see changes with the, I mean, this was done last year. Would you expect to see different results if you were to take the same test again this time?
Thank you. So now we are not sure because of different type of virus, and now we have like a Delta virus, and it's coming Epsilon virus, and we know that it goes straight to the lungs. So I'm not sure whether if we do the study. But I still found that when my students, my MOs doing the smell test, they still have olfactory loss. But how severe is that? We are not sure.
All right. So with that, thank you very much, Professor, for delivering the talk. It was very good. So we move on to the next speaker of the day. He is the last speaker for the first session, just before we go for our break. So I would like thank you again, Professor. I would like to humbly invite the Associate Professor, Dr. Muhammad Hasni Jaafar, to the screen to deliver his talk on the biosurveillance study to investigate the possible airborne transmission of SARS-CoV-2 indoor environment. The case study for COVID-19 screening clinic here at the Hospital Chancellor Tuanku Mukris Operational Room. Now, our speaker is a renowned environmental health and toxicologist from the Department of Community Health, the Faculty of Medicine. He is a registered consultant and an expert panel for the health impact assessment with the Department of Environment, and is working on various clinical toxicology and environmental impact studies throughout the country. Ladies and gentlemen, please welcome to the screen our esteemed speaker to the floor, Dr. Muhammad Hasni Jaafar. Without further ado.
Bismillahirrahmanirrahim. Assalamualaikum and good morning. Thank you very much, Mr. Chairperson, for the very brief introduction. And before I start, I would like to thank to the Secretariat of the Medical and Health Research Week for inviting me today, this morning. Okay, hang on, I'd like to share the slide. Okay, today is I'm going to present what we have done for this the special grant that we received for the COVID-19. The running title is a biosurveillance study to investigate possible airborne transmission of SARS-CoV-2 in indoor environment case study for COVID-19 screening clinic in the HCTM operation room. If those don't know what the biosurveillance is, something like we gather and analyze the data and something to look at the overall situational awareness. So this is the title for the paper that we published is particulate matter PM2.5 as a potential SARS-CoV-2 carrier. We published a scientific report 2021 it's a Q1, and below there is a list of the researcher that we meet we do together. Okay. Sorry. Okay, this abstract. There's an introduction, and then as usual, talking about how the rapid spread of the COVID-19 that raised a lot of questions about the route of transmission. So initially, we know that it's through the respiratory droplet, but however, we consider also by the forming and also the aerosol, which also through the particulate. So this objective study to assess the fine indoor air particulates with the diameter of less than 2.5 equal and less than 2.5 micrometer as the virus transport agent. If you want to imagine how small is it, we take our hair about 70 micrometer, divide by 10, and then divide further by 4, about 40 times. So the methodology, we collect this particulate PM2.5 over 4 weeks time using a 48 hours measurement interval in 4 separate wards in the HCTM, which contain all the COVID-19 during our first phase of the pandemic in Malaysia. Okay, what we found that the SARS virus RNA load on the surface of the PM2.5 with the ward with the greater number of patients is higher. And we conclude that there's a link with the virus laden PA2.5 and the ward design. And also we link that the symptom and the number of the patient in the ward will influence the number of the virus load. As introduction, I think we really know that previously the SARS is transmitted through the respiratory droplet. Until the WHO mentioned in the middle of the last year that we talk about more on the airborne. And we know that the last respiratory droplet more than 5 micron transmission occur when the person is a close contact with someone who has a respiratory symptoms such as coughing and sneezing. And then those with the smaller size, which are less than 5 micron, have a potential to remain in the air, suspended in the air for a certain period of time and can be spread to a greater distance, more than 6 meters in certain study, which is similar as happened in the outbreak of tuberculosis, measles, and chickenpox. And the several studies have already demonstrate that the SARS virus is transmitted through the respiratory droplet, and but for the aerosol-borne or the particulate transmission is still limited during we start this project. And for those, just for mention, the PM255 is very fine solid aerosol that can go straight down to our alveolus, and it can bring all kind of the foreign body, including the COVID virus to our alveolus, which suspended in the air for many hours. They derive from the outdoor source like motor vehicle, open burning, maybe also from industrial emission. And prolonged exposure to this small particulate usually can cause impact on the human health, because this fine particle easily inhaled can penetrate deep to our lungs. So the objective of this study is we try to investigate the role of this PM2.5 burden and the SARS-CoV-2 load in the ward with the COVID-19 patient in our hospital. It's a cross-sectional study, which we did in the 4 type of room. The first one is a single room. You can see my cursor here is a single room, 1 patient here. Okay, we have this mini valve to collect the particulate, and we also have the sense for the other parameter. And for the B type is the general ward B. We have many patients there, and a part of the mini valve and the airbox sensor there. The ward also have the air purifier. Okay, at the end of the ward, I will tell you whether it's significant or not to have this air purifier. And the ward C is also quite smaller, but smaller number of patients, and also with the 1 air purifier and all 2 gadget that we use. And the ward D have a smaller number but bigger space. And we have the same 2 gadgets that we use and 1 air purifier. In this methodology, we use mainly the indoor air sampling. So we did from 31st March to 29 April 2020. We use 2 types of instruments I mentioned just now. One is an airbox sense to measure the concentration of PM2.5, right? And we have also the low volume sampler to determine the virus load on the PM2.5 that we trap on the filter paper. And before we do the sampling, both instruments were cleaned using the ultraviolet C light for 20 minutes and dissipated with 70% alcohol, and of course be calibrated. And then the data that we receive from the airbox science will be synchronized via the TeamPack, cloud storage, and analyzed using the MATLAB software. And for the second one, for the low volume sampler, just now we have the viral load. So we have on the food water, the paper filter. So we do the viral nucleic acid extraction and RT and qPCR analysis, by which the membrane filter was divided into a smaller part, and then we immerse in the 1 milliliter sterile of the RNS-free water in a separate tube. And then we vortex the filter to release the viral particle. And then we centrifuge to remove all the particle. And then the supernatant were transferred to the new micro centrifuge tube for the viral nucleic acid extraction. And then this viral nucleic extraction, we use the viral nucleic acid extraction kit too. And this all been done in Bangi at the lab in Bangi. Purified nucleic acid containing sample was kept for -28 degrees Celsius for the reverse transcript quantitative real-time polymerase chain reaction (PCR) analysis. So this is a result of our study. According to the type of the wards, as mentioned just now. So the smaller one is a single ward, single room. The concentration of the PM2.5 is about 11.25 microgram per meter cube. Yeah, and so there's no minus the meter cube. And then we also detect the virus COVID-19 on the surface of the PM2.5. And the special about the room, there's no purifier. Okay? The second general ward is the biggest one, I think. The PM2.5 is about 70.58 microgram per meter cube. And also we detect the virus COVID-19 on the surface. And there are 2 air purifier, but yeah, either the surface is enough for these 2 air purifier. We not study on that. And then the second general ward is C, which have the 17 patient in that ward, with the mean concentration of PM2.5 was 40.6. However, we don't detect any COVID-19 virus on the surface of the PM2.5, even though all the 70s COVID patients. And only 1 air purifier in that ward. And then the last ward is a smaller ward, general ward, 8 beds. We detect PM2.5 of about 7.6 microgram per meter cube. However, again, we don't detect any virus, the COVID virus on the surface of the PM2.5, and there is 1 air purifier there. Okay, so as a result, we conclude that we can say that the higher PM2.5 concentration are detected in the ward with a greater number of patients. Then the higher PM2.5 concentration can be contributed by the physical activities such as walking, walking of the health workers and also patients. And then the PM2.5 concentration measured in this study is slightly lower than reported in the European urban hospital. So our hospital is cleaner than the hospital in the Europe. And then SARS-CoV-2 RNA and 1 nucleocapsid gene was isolated from the filter membrane, isolated from the low volume sampler from the certain ward without air purifier. And there is a degree of the virus shedding from patient due to coughing, sneezing, and diarrhea. This one, the single ward just now, shows that she had a very active symptom, and it has been reported to influence the number of the virus particle in the environment. So we also find the same finding. And then the increased viral particles due to the shedding in a poorly ventilated environment might increase the virus PM2.5. Also, we also find this some kind of the association there, but not really a correlation. And also be supported by 3 other studies. And although certain people said the air purifier is very effective in the COVID-19 control, but in our study we found that this effectiveness is particularly to remove the PM2.5 is remain unclear. Okay, the air filtration can be reported elsewhere to reduce barrier loading, but we're not certain on that. We can't find the expression in this study. So the conclusion and recommendation, there's a potential of PM2.5 as a carrier for the SARS-CoV-2 virus. There's been this airborne transmission. So this is one of the among the early study in Indonesia that we prove that the COVID-19 is also, apart from the aerosol, it also can be transmitted through this airborne. Meaning the airborne is more, we can be, I have to be more cautious when it's airborne transmission because we have to know the character of this PM2.5. It's very light dust. It takes hours to settle to the ground. Yeah. So it may take about hours, about 2 or 4 hours in the ward before everything settled by the gravity. We can see the PM2.5 very small in the size. So we're not aware because whether we are exposed to this PM2.5 or not. Yeah? However, there's no direct correlation between the concentration of the PM2.5 at the carrier and the virus load of the COVID-19. And we also found that the PM2.5 is generated from the human activity in the healthcare facilities, in which, as I mentioned just now, usually this PM2.5 is from the motor vehicle combustion, from the industrial emission. And but in this study, we found that the PM2.5 is also present in our hospital wards. Okay, in which we assume as a clean environment, the most cleanest, the cleanest environment in the hospital, but yet still we have the PM2.5 in the ward and this maybe we have to look at this very seriously, how to reduce this dust, the small dust in the ward, because this may influence all present on the microbes actually for the COVID-19 at this present time. And the degree of the virus shedding from the symptomatic patient with all these influenza-like symptoms, coughing, sneezing, all the things, have very high influence on the presence of the COVID-19 on the surface of the PM2.5. So our recommendation is everybody has to take all possible precaution about this airborne transmission. It's not only aerosol, but also airborne transmission, actually in an indoor environment, seriously. Meaning that even the patient is already left the ward, maybe the dust still in the ward, and then the virus is still on the PM2.5, and when you enter the room without the patient there who already left, you might continually expose. You continually have the risk of the exposure to the COVID-19. So these are the reference for the study. And this study was supported by the UKM Special Fund with COVID-19 and by the number COVID 2020-004. By that, I would like to thank to all of you for listening to my talk today. Okay, thank you very much.
Thank you very much, Dr. Hasni, for the enlightening presentation. So I'll open the floor. We have like a minute or two for Q&A. I think this is something that we can all relate to and can be applied not just in the hospital setting, as well as our homes and the places that we go. And at the moment, there is no question yet, but I do have one question though. I may have missed this in your presentation. If you were to collect those data in a much longer period, would you see something significant correlations between the particulate and SARS-CoV-2? Or is it just, I know you mentioned again the orang yang the number of patients resided dalam ward tu pun would actually play a role. But if you were to take this, if you extend the experiment much longer, would you think you'll be getting any correlation in that sense?
Well, I think it depends on whether the patient, the group of patients have the influenza-like symptom.
Oh yeah.
Because most of the time that day that when we carry out this study, you remember we have the group of the TAFE student that they admit to the ward. So most of them are asymptomatic. Asymptomatic. So they don't, maybe they have the disease, but they don't spread out the virus to the environment. But for that single bed, she have a very active symptom, and that shows the high virus load on the particulate matter 2.5. And if you extend the study, I think the similar finding will be obtained, because it's not because the duration is based on the dose at that particular period of time. So with the higher dose at the time been escalated out, then we can get this kind of the exposure.
All right. So thank you. So I think we are up to the point now where we will take a break. Thank you very much again, Dr. Hasni, for your presentation. I really appreciate
Thank you
that.
very much. Bye-bye.
So we shall take a short break, 20 minutes break, and we shall resume again with our next speaker, with our list of next speakers, starting with Dr. Wong. So see you guys again at 10:10 a.m. Encik Khaide will show the screen for you to register your attendance for today's session. Thank you very much. So we'll see you again. Yeah.
Thank you.
Tapi satu view je lah. Tapi kalau ada 2 panelis,
Ladies and gentlemen, we'll be starting in 2 minutes' time. Yeah, 2 minutes' time. Sorry for that. Ladies and gentlemen, hope you had a nice break earlier just now. So we shall be continuing with our symposium. Our next speaker for today is none other than Dr. Wong Konkan from our Department of Microbiology and Immunology. His research area centers on epidemiology, burden of illness, and strain sequence heterogeneity, or on respiratory viruses in human. His current work is on the pathogenesis and infectional mechanism of COVID-19. Our esteemed speaker will be presenting his work, a pilot study on ACE2 expression as a risk factor to assess severity in COVID-19 patients. Without further ado, please welcome Dr. Wong Konkan to the screen. Greetings, Doctor.
Yeah. Thank you, Mr. Chairman, Dr. Lukman. Let me share the screen. Yeah. Okay. A very good morning to all the participants in this program. Welcome to Joint Module G Symposium. My name is Dr. Wong Konkan. I'm from the Department of Microbiology and Immunology, Faculty of Medicine. Currently, I'm on duty at Microbiology Lab, JPMD, a team member for the COVID-19 diagnostic. In this section, I would like to explain some of my research findings in a pilot study on the ACE2 expression as a risk factor to assess severity in the COVID-19 patient. The goal of the presentation today is to explain what is the role of the ACE2 in the COVID-19 infections. Let's start with a little bit of background of the study. Okay. Since December 2019, a previously undiscovered virus, severe acute respiratory syndrome coronavirus 2, has caused a devastating global pandemic. Currently, available data on the novel coronavirus, SARS-CoV-2, robustly support that OH and underlying medical conditions such as hypertension and cardiovascular disease are high risk factor for the severe form of the COVID-19. However, the mechanism to which this risk factor act remain to elucidated. Angiotensin converting enzyme 2 ACE2 is an enzyme that is used to regulate functions in the cells. It is present in the many cell types, especially epithelial cells of the human brain, lung, liver, heart, and kidney. ACE2 is critically important to regulate processes of the inflammation, blood pressure, and wound healing. It helps to reduce the inflammation of the death of alveoli cells in lung. So before I move on, I would like to share a video to you. What is the mechanism ACE2 to the cells?
SARS-CoV-2 is the novel virus that causes the COVID-19 disease. The ACE2 receptor exists in abundance on the surface of lung cells and is a target for the SARS-CoV-2 virus. ACE2 proteins are important to enzymatic functions, influencing blood flow to the organs, such as lungs, heart, and kidneys. The spike proteins protruding from the virus attack ACE2 receptors to gain access to the interior of the human cell, where they can replicate.
Okay, we move on. SARS-CoV-2 binds to the ACE2 in order to initiate the membrane fusion as a point of entry into human cells. If compare binding affinity to the ACE2, SARS-CoV-2 has 10-fold to 20-fold greater than the SARS-CoV-2. Since SARS-CoV-2 spikes the ACE2 receptor, it can be expected higher ACE2 expression when an individual infected with this virus. ACE2 plasma expression is essentially undetectable in the healthy individual. A study shown plasma ACE2 was significantly higher in the patient with the active COVID-19 disease and in the period after the infections. Increased circulating of the ACE2 has been associated with the increased risk of the major cardiovascular events. ACE2 level were recently shown to be significantly elevated in the serum from smokers, obese, and diabetic individuals. The general objective for this study is to assess the ACE2 expression as a risk factor of COVID-19. Specific objectives are to profile soluble ACE2 in the asymptomatic and mildly symptomatic subject compared to control, and also to profile soluble ACE2 in smoker compared to non-smoker. Study populations. Healthcare worker and patient in the UK University Kebangsaan Malaysia Medical Center, in which PCR for SARS-CoV-2 has been performed. Epidemiological data including social demographic, COVID-19 clinical symptom if the previously positive for COVID-19, history of the underlying health issues, and history of smoking. Specimen is the plasma to measure the level of the ACE2 shade in blood. For method, we are using the human ACE2 ELISA kit. The kit came with the pre-coated ELISA plate. When we put in the patient's serum, ACE2 protein in the sample will interact with the captured antibody and combine with the substrate and TMB. After incubation, the plate was put in the ELISA plate reader to obtain the reading for the ACE2 concentration. Here is the result. All the data we analyzed by using the Whitney test. First, we study whether the circulating ACE2 differ between COVID-19 patients with a symptom and asymptomatic group. Surprisingly, plasma ACE2 show a clear overlap between the groups and no significant difference between these two groups. We performed the same analysis on the plasma ACE2 in the group with the underlying health issue between COVID-19 positive patients and COVID-19 negative patients. There was significantly difference between COVID-19 positive patient and COVID-19 negative patient for circulating ACE2 if the individual had underlying health issue. Again, we further tested the association of the plasma ACE2 with the health control between COVID-19 positive group and COVID-19 negative group. Again, evaluated plasma ACE2 was significantly associated with the COVID-19 positive group. The level of the ACE2 increased when a healthy individual infected with COVID-19. Finally, we tested the association between plasma ACE2 and smoking habit. Obviously, we found circulating ACE2 was significantly elevated in the smoker compared with non-smoker. Our analysis described the circulating ACE2 in association with clinical outcome in patients with COVID-19 disease. However, it was no major difference of a plasma ACE2 concentration between the asymptomatic group and symptomatic group. This analysis was contradicting previous finding by a study that showed highly correlation between COVID-19's severity with a high ACE2 expression. However, in healthy group control, plasma ACE2 was significantly different between COVID-19 positive and negative patients, which is in line with the result of a recent study that shows circulating ACE2 is increased in the patient with active COVID-19 infection compared with healthy controls. The same finding also found in the group of patients with underlying health issue. Plasma ACE2 was significantly different between COVID-19 positive group and COVID-19 negative group. It might have seemed reasonable to hypothesize that expression of ACE2 will be increased for the COVID-19 patient. We observed a low plasma ACE2 mean value among the healthy control compared to the underlying health issue group. The same finding was published by a study, proved that ACE2 was highly expressed in the patients with the comorbidities associated with the COVID-19 infections compared to control individual. Here we found ACE2 level was shown to be significantly elevated in the serum for smoker. ACE2 level were elevated in the smoker agree well with a study showing upregulation of the ACE2 in the respiratory tract of the smoker. This raises the question whether the upregulation of the ACE2 by smoking increased the ability of the SARS coronavirus 2 to enter the cells. A study conducted by the Brake et al. Clearly explained the ACE2 levels are increased in the airway epithelium of smokers. They have a higher risk for the COVID-19 infections. Differences in plasma ACE2 does not seem to be explain the risk of the severe COVID-19 disease. However, plasma ACE2 was associated with the pre-existing lung disease, diabetics, and immunosuppression. It's also associated with the age, which is in line with a recent observation, showing higher serum levels of the ACE2 in adults compared to a pediatric cohort. In conclusion, we still believe that elevating plasma ACE2 higher the risk of the development severe and fatal of the COVID-19. This suggests that measuring plasma ACE2 adds to the value of the clinical available data to help predict disease outcome in COVID-19. There are some overall limitations of this study. Severity criteria must have some induced bias. a Chi serum sample might not suitable for the measurement of the ACE2 concentrations. And because of the sample size collection of this study is small and was impacted our statistical analysis. This work should later be reproduced with a larger cohort of the patient, including more patients with the severe form of the COVID-19. Last but not least, I gratefully acknowledge the assistant and helpful contribution of all the members in my team. This is my list of the reference. Okay, this is the end of my presentation. Once again, thank you for following me to be here this morning. Hope that this information has given you a much clearer understanding of the ACE2 relation to the COVID-19. Thank you.
Thank you very much, Dr. Wong. It was very short and succinct. We have ample time for Q&A session. Okay, let's see. Yeah, so let's see. So we have one from Ms. Sabrina Balakrishna. Good morning. Yes. May I know how many subjects were recruited, please? Yeah, she was asking about how many subjects were recruited in the study.
When we set the time period of the study, it's around 160 patient and control. So, but not all of them have fulfilled the criteria because history of smoking also, some of them quit smoking, and then basically the sample size is quite small for this study. But as I say in the limitation for the study, we would like to have the bigger cohort later on.
Right.
Yeah.
This is a personal question for me. Would you expect to see ACE2 to be different in other biological fluids in response to COVID-19? Or is there any study that looked into other biological fluids?
Yeah, actually you can just collect the cells, nasal cell or any cells from your body, and then you extract it, you still can get the ACE2. But for the plasma serum, plasma ACE2 is the most I can say the easier way to get the reading for the ACE2. Yeah. That's why we choose a plasma as our sample to measurement for the ACE2.
Right. Okay.
Yeah.
So I mean that's it from me. So do we have any other questions coming in?
Yeah. If any question with the diagnostic, also can ask with this platform.
Yeah. This is the best time. I want to ask. We have a number of participants here, and it is an emerging study.
Yeah.
So I mean, we can expect a lot of stuff. Like are there any omic studies have been applied? With ACE2. That is one way to ask. But if there is no other, then I guess we may have to cut short the time, and I hope that's okay for you.
Sure.
Yeah. Okay. All right. Yeah. So with that, we on behalf of the organizing committee, we thank you for your presentation. Yeah. And for those who may have questions along the line, you can put in the Q&A box, and we can allay those questions back to Dr. Wong via to email or anything. So maybe at the moment it will be
maybe some new variant. Delta, Lambda.
Is there? I mean, do you think that there will be a difference if it was in a different variant? Then?
Yeah, definitely. Yeah.
Obviously, again.
Yes, because mutation will cause the different variant of the virus. The more people you get the infection, the more easy way to get the mutation.
Right.
Yeah.
Betul. I agree. I totally agree. Okay, so with that, thank you very much, Dr. Wong.
Thank you.
We shall continue with the next speaker. I hope
thank you, Dr. Loman.
Thank you again. All right, so up next, the floor would like to invite the Associate Professor, Dr. Noor Rafi'ah Tumian. Our esteemed speaker is a clinical hematologist from the Clinical Hematology Unit. Her area of research is on malignant hematology in adults and venous thromboembolism. The presentation for today is the association between COVID-19 infection and coagulation parameters. Please join me in welcoming Dr. Noor to the screen. Please welcome Dr. Noor. Thank you very much. Hello. Yes.
Okay, Assalamualaikum and a
hello.
very good morning to everyone.
Alaikum salam.
Can everyone hear me?
Yep, loud and clear. All good.
Okay, I share my screen. Okay, hold on. Yeah.
How are you today?
I'm fine.
Good to know.
Okay. Yeah, yes. Okay, hold on. Okay, can you see my slides?
Yep, yep.
Okay. Okay, Assalamualaikum and good morning to everyone. Thank you, Dr. Muhammad Luqman, for the kind introduction. So, I'm Dr. Norafi Atumian from the Clinical Hematology Unit, Department of Medicine, Faculty of Medicine, UKM. So the topic of my talk today is coagulation profile among non-severe COVID-19 patients in a single tertiary center in Klang Valley, Malaysia. Okay, so these are my co-investigators, which include Prof. Nur Rashikin and Dr. Azlin from Department of Pathology, Dr. Patrick and Najma from Department of Medicine, and Associate Professor Dr. Nur Zilawati Sahab from UNIMAS. And the study was mainly carried out by one of the master student, Dr. Alif Saifuddin, okay, during his final year MMed program in the Department of Medicine. Okay. So this is the outline of my presentations. Okay, so as we know, in December 2019, there was an emergence of clusters of pneumonia cases in Wuhan, China. So, whereby the COVID-19 virus was emerged at that time. So, fast forward 4 months later, WHO declared it as a global pandemic at that time. Okay, so what do we know about SARS-CoV-2? It belongs to the beta coronavirus family, a single-stranded RNA virus which has the S proteins form spike that extend from the surface that allows the attachment and fusion to the membrane of host cell. So in February 2020, the official name of SARS-CoV-2 was developed. So in Malaysia, the first reported case was in January 2020, and we have endured 3 waves of COVID-19 infection, and currently still the 3rd wave, which has not, subsided. And in fact, we have about 20 to 23,000 cases per day, okay, as you can see now, okay. But hopefully with the vaccination, things will be more settled soon. So how does COVID-19 infection affect the hemostasis and coagulopathy? So as we know, the SARS-CoV-2 virus, it will combine to the ACE2 receptor, and it also has an interplay between the cells intravascularly. So it will stimulate pro-inflammatory chemokines and cytokines and interaction with the cells intravascularly, including neutrophils, platelets, and subsequently develop microthrombi, and further on causing venous thromboembolism. Okay. So at that time, earlier on last year, sometime in March 2020, so there were reports on coagulation parameters derangement in COVID-19 infection, but it did not fit into the sepsis coagulopathy. Okay, so what about the D-dimer level at that time? So it shows that patients with severe COVID-19 infection had elevated D-dimer, okay, as compared to those non-severe cases, okay, and the severe cases also included patients who are mechanically ventilated, ICU admissions, and also death. Okay, so you can see the studies from, especially from China, okay, showing that those, as I mentioned, non-survivors and severe COVID-19 infection had elevated D-dimer as compared to those who actually survived. And the median D-dimer was also found to be in one of the studies 4.6 milligram per liter as compared to 0.6 among the survivors. And what about the platelet level? So surprisingly, okay, thrombocytopenia was observed in only 5 to 41% of COVID-19 patients, and this is usually mild. So those with platelet counts of less than 100,000 was seen in only 5%, and as compared to patients who actually have severe sepsis. Okay, so the platelet counts were even lower in those with severe sepsis. Okay, however, based on the meta-analysis of 9 studies at that time, those patients with low platelet count is associated with an increased risk of severity, and especially associated with mortality. Okay, however, there is scarcity of reported data on the coagulation profiles of non-severe COVID-19 patients, in particular those who are asymptomatic and without pneumonia, especially in the Southeast Asian countries. Furthermore, the incidence of VTE among those asymptomatic and non-severe patients is not known. Especially during the first and second waves of COVID-19, whereby the limited knowledge and understanding of this epidemic at that time. Therefore, we constructed this study with these objectives. Okay, so firstly, to determine the coagulation parameters in non-severe COVID-19 patients. Secondly, to compare the difference in coagulation parameters between the clinical categories. So as we know, we have category 1 to category 5. So category 1 and 2 include patients without pneumonia versus category 3 and 4 in which patients had pneumonia. And thirdly, to compare the coagulation parameters at positive and negative COVID-19 real-time PCR according to the clinical categories. Okay, at that time, we wanted to do a prospective prospective observational study. However, as you know, the cases started to decrease and drop from May onwards, which was after the approval of the study. So we had to do a retrospective analysis of the study. Okay, so this was carried out in the COVID wards in the Hospital Chancellor Tuanku Mukhlis, Kuala Lumpur, and the study duration was between 20th March 2020 till 30th April 2020, and it included all confirmed positive COVID-19 patients. It was a purposive sampling, and those patients who are included in the study were those with at least one complete coagulation parameters. So when I say complete coagulation parameters, that include the platelet count, prothrombin time, activated partial thrombin time, fibrinogen, and also D-dimer levels. We included patients who were 13 or more, which were admitted in the adult COVID-19 patients. The study instruments included electronic medical records and patients' medical files, and these were the parameters that were traced and tabulated. Okay. Okay, so this doesn't come up well. Okay, so on admission, we collected the demographic data for the patients. Okay, we collected the, oops, sorry. The demographic data for the patients and the coagulation profile, which included the parameters that I mentioned just now. And subsequently in the ward, we documented the treatment that the patients received and the duration of a patient's stay, and this was the HUKM consensus in the treatment of COVID-19 and management that was being produced in April 2020. Okay, so as you can see, it is according to the categories, okay, category 1 to category 5. Okay, and as you can see at that time, hydroxychloroquine was being used. Okay, so this was way back 1 year plus ago when we did not know much, okay, about the disease. Okay, and those with raised D-dimer were comments on low molecular weight heparin. Okay. And subsequently, where the discharge criteria included negative PCR, okay, and we also documented the coagulation profiles taken at discharge. Okay, the statistical analysis was performed, okay, depending on whether the data is quantitative or categorical. So we use all the analysis method as presented here, okay, which included the t-test for t-test t-test for the parametric, okay, whereas a man-Whitney U for the non-parametric data, and also chi-square for the categorical data. Okay, so what was the results at that time? So at that time, 203 COVID-19 positive patients were admitted to the wards. Okay, however, 80 had to be excluded because the complete coagulation parameters were not available. Therefore, we only included 123 patients. So in these 123 patients, okay, 88.6% were in category 1 and 2, which means they are asymptomatic or symptomatic but without pneumonia. Whereas 14 or 11.4% were in category 3 and 4. And this is the clinical stage, as I mentioned, about category 1 to category 5. So at that time, HCTM, I mean, according to the MOH directive at that time, so we only admitted those in category 1 to 4, whereas those critically ill category 5 were transferred to Hospital Sungai Buloh. Okay, so 109 patients were in the category 1 and 2, whereas 14 patients were in category 3 and 4. Okay, so what did we find on the demographic and the clinical characteristics and the coagulation parameters? So for all patients, okay, so these are the non-severe COVID-19 non-ICU patients. So we found that the median age was 34, okay, whereas when we compare category 1 and category 1 and 2 versus cat 3 and 4, so those in cat 3 and 4 were, the median age was significantly different from cat 1 and 2. Okay. And what about the comorbidities? As you can see here, there was a higher number of patients with comorbidities in Cat 3 and 4. And subsequently, what about the coagulation parameters? So if you can see here, the platelet counts were still within normal limits. Okay, in all patients, the mean platelet was 277. Okay, and however, when we compare, there was a significant difference in the platelet levels at presentation or at RT-PCR positive when in category 3 and 4 versus category 1 and 2. Okay. Okay. As for D-dimer and also prothrombin time, okay, if you can see here, there was just a tendency, okay, of higher D-dimer and prothrombin time in those in Cat 3 and 4. Okay. However, these findings were not statistically significant. So what happens to the coagulation parameters at diagnosis, okay, which is at RT-PCR positive and RT-PCR negative. Okay, so the graph on the left-hand side is for platelet count, whereas the graph on the right-hand side is for D-dimer. So those with the diagonal pattern, okay, is for RT-PCR positive, whereas those with the dots is for RT-PCR negative. So as you can see here, there was a statistically significant difference, okay, in the platelet count and D-dimer at RT-PCR positive versus RT-PCR negative in patients with Cat 1 and 2. Okay? So the bar chart, okay, on the left side, okay. So what about the prothrombin time, APTT, and also fibrinogen? Okay, as you can see here, the APTT was also statistically significant. There was a statistically significant difference in the APTT between RT-PCR positive and negative in those in category 1 and 2. Okay, so what about those in Cat 3 and 4? Okay, in those in Cat 3 and 4, so we found there's a tendency in the a tendency for the decrease in the platelet, D-dimer, and also a prothrombin time. Okay, when we compare on admission and at discharge. Okay, or the other way to say it is from RT-PCR positive and RT-PCR negative. And subsequently, a description on the clinical outcome. So all 123 patients which were included in the study recovered and were discharged. One patient was transferred to COVID ICU for type 1 respiratory failure, but this patient only required non-invasive ventilatory support. And one patient was actually diagnosed with pulmonary embolism, and this patient surprisingly was asymptomatic throughout the illness. Okay. So as for the discussion, firstly, in our cohort of non-severe, non-ICU patients, platelet and coagulation parameters were within normal range except for a borderline high PT, about 10.9 seconds. Okay. There were two other local studies which reported abnormal blood counts and biochemical results according to the severity of disease and symptoms, but there was it wasn't mentioned the details of the coagulation parameters. So to date, there's no detailed study for the coagulation parameters alteration, especially those who are asymptomatic, non-severe, non-ICU setting. So secondly, patients with category 3 and 4 group had higher platelet levels at RT-PCR positive as compared to those category 1 and 2. And although interestingly, the platelet levels were still within normal limits at that time. Okay, in a study by Yin et al. 2020, it was found that COVID-19 patients had higher platelet counts than non-COVID-19 patients. Okay, 215 versus 188. Okay, so these differences in our cohort could be a reflection of different categories and phases. As you can see, at that time we did not have anyone in category 5, so they may have a different coagulation parameters results. Okay, so because they are mainly those who are severe and also requiring ICU admission. Okay, so this higher platelet level in category 3 and 4 group may be explained by the increase in platelet production via few possible mechanisms. Okay, these may include the cytokine release. Okay, all these acute phase reactant, okay, which leads to megakaryocytic production and thrombopoietin release, and also hypothesis of stimulation of the lung megakaryocytes by thrombopoietin. Okay, Cat 3 and 4 patients, okay, showed a tendency, okay, because there's no statistically significant difference, to have a higher D-dimer and prothrombin level on admission. And we also found that there was a higher percentage of patients with raised D-dimer, especially more than 1.5 microgram per ml in Cat 3 and 4. So this actually shows that the changes in coagulation parameters may occur at an early stage. Okay, even those in Cat 3 and 4, they already had the changes in the D-dimer levels. Okay, although it was seen at a lesser degree. So findings from other studies which mostly mention about severe COVID-19 infection. So as you know, D-dimer levels were significantly higher in those with severe clinical status. So just a comment. Okay, so majority of our study patients were asymptomatic. So there were about 109 of them, and they only had mild infection. Okay, in contrast to the other published reports, which are mainly on severe COVID-19 patients. And comparing the coagulation profile at RT-PCR positive and negative. So those in Cat 1 and 2, there was a significant difference in the platelet counts, D-dimer and APTT levels. Okay, whereby those in Cat 3 and 4, there was a tendency of raised platelet counts, D-dimer and prothrombin time during RT-PCR positive, which decreased during the conversion to RT-PCR negative. And since the levels were still within normal range, so the significance of these findings needs to be ascertained in a larger study, which may be correlated with the actual viral loads. Okay, and in the earlier study by Tang et al. In China, so those who actually did not survive, okay, there was a progressive rise in the levels of prothrombin time and also D-dimer. And we also, as I mentioned just now, we also found a patient who was asymptomatic throughout the illness, but the D-dimer at presentation was raised 3.72 microgram per ml, which was further investigated and found to have an incidental finding of pulmonary embolism. Okay, so in a report by Al-Harti et al., so this author also reported 2 cases of pulmonary embolism in asymptomatic COVID-19 patient. Okay, but then subsequently this patient had shortness of breath, chest pain, and also leg swelling, okay, which pointed towards VTE. Therefore, as we know, high prevalence of VTE among severe and ill patients have been reported. Okay, but this is rarely seen in asymptomatic patients. However, with the current situation that those who are in Cat 1 and Cat 2 being monitored at home, okay, so we really have to monitor these patients closely, especially if they have comorbidities. Okay, so what is our study strength? Okay, so this is one of the local reports of serial coagulation parameters, demographic and clinical characteristics of non-severe, non-ICU COVID-19 infection in Malaysia. Among the study limitations are we were not, as this was a retrospective analysis, so the serial coagulation parameters were not, we were not able to perform it at a more regular interval that can, potentially show more precise dynamic changes in each test. Okay, this was due to the limited time and frequency of contact, okay, between the medical personnel and COVID-19 patients. And as you can see, we had a small number of study participants and even smaller numbers in the Cat 3 and 4. And none in Cat 5, in fact. Okay, so that was during the second wave of COVID-19 infection in Malaysia. And as I mentioned just now, it was the MOH policy at that time to centralize the treatment of severe patients in Hospital Sungai Buloh, and subsequently the sudden drop of COVID-19 cases in Malaysia. Okay. So what we have learned so far, so those patients with non-severe COVID-19 patients had shown mild dynamic changes in the platelet levels and coagulation parameters during the admission, okay, which was the RT-PCR positive, and subsequently during negative conversion. Also, the changes were of lesser degree. Frequent monitoring of coagulation profiles may not be required in patients in Cat 1 and 2. However, if their clinical condition deteriorates, then it has to be, frequently monitored. Performing D-dimer level at admission. Okay, so those who require admission is beneficial even if they are asymptomatic, and raised D-dimer may warrant further investigation for venous thromboembolism. Okay, so some acknowledgements. So part of this study just won the prize for oral presentation in the recent annual scientific meeting of the Malaysian Society of Hematology earlier this month. And our special thanks to the Dean of Faculty and also Director of the hospital for their continuous support, and also the assistance of the COVID-19 team members during the study. Okay, and we are also grateful for the COVID-19 Research Grant 2020. Okay, thank you.
Thank you very much, Dr. Nora, for the lovely presentation. It was very enlightening in that sense. I open up for one question as we are running out of time. One question on the floor, up to the floor, if there is any. If there is not, then I have one question for you. This is like a novice question again. Do you plan on using or developing like a diagnostic tool with regards to this, or is it not worthy of that being a biological marker for COVID-19 patients or potentially COVID-19 patients. Do you think that there is a worthy research onto that part?
Dr. Luqman, that's a good idea. So probably it's like a risk stratification score, right? Okay, to to sort of delineate which patients need to get admission, and subsequently monitored closely. And but that actually warrants a different study. So the validation and also the of this risk scoring system,
All right. So with that, thank you very much, Professor Dr. Noor, for your time and presentation. We really appreciate that. So any further questions can be, you can text me personally. I know I have one text me with regards to the previous presentations, but any further questions, you can send them to the chat box or in the Q&A chat box. We can allay those questions back to the presenter. So thank you once again, Dr. Noor. And we shall proceed with the next speaker of the day. Thank you very much again. Next speaker of the day is the associate from the floor. Would like to invite the Associate Professor Dr. Ramizi Mohammed to the screen. Our esteemed speaker is an Associate Professor from the Department of Electrical, Electronic and Systems Engineering. He specializes in power engineering, instrumentation and energy harvesting. He will present his work on the pemantauan secara dekat peluncuran pandemik COVID-19 di Malaysia menggunakan model SEIR. So please welcome to the screen Dr. Ramizi. Thank you very much.
Okay, Assalamualaikum warahmatullah. Thank you, Dr. Let me share my slide first. Okay, can you see my the slide presentation? Right. Okay. First of all, I would like to thanks to Dr. Rahman for chairing the session today, and to the organizer. I would like to apologize to my fellow medical doctors here. It's a bit awkward for me to present the because the title is SEIR model. Solution for Malaysia COVID-19 pandemic projections. The title presented by Dr. Rahman was the title for the whole project granted last year, and even the project code grant was ended by end of early this year. So it's a bit awkward for me because it's merely about mathematics, it's merely about statistics. So for those who do not understand, just bear with me, and hopefully I can try to explain the best so that everyone could understand. Okay, short introduction. I'm talking about the model. Model means a mathematical model, because earlier when the outbreak happened, or when the pandemic happens, even our DG, Dr. Nur Hisham, he did mention something about the infectivity. He did mention something about the curve. He did mention something about the R0. So what are those terms, right? So the COVID-19 pandemic can be modeled using SIR or SEIR, or even some of the researchers, they come up with different type of names. So the letter stands for susceptible, exposed, infectious, and remove. And literature can be found from many studies. So the developed model was our model based on SEIR, which adopted from two papers, Kulin et al. And He et al. So the developed model used three control parameters known as government control strategy, early detection strategy, and public response. So there are keywords that I would like to emphasize here. The keyword is compartmental. So what is compartmental model? The green icon there stands for susceptible. It is actually an individuals that not yet infected with the disease. Okay, and then we do have the E stands for exposed. Is the compartment of population who have been exposed to the disease. Okay, whether it is infected or not, then it is not yet infected but has been exposed. And then we do have I, noted with the red color, denotes as the individuals who have been infected with the disease. And we do have the R, the light green and the brown color, is the compartmental model used for those who have infected and has been removed from the disease. And this can be those who have the immunization, recovered or death. Yeah, recovered or death. Okay, suppose there is an infected person travel from overseas, and then they travel to Malaysia. So everyone in Malaysia is a healthy person, and everyone is susceptible. When we open the border, they happens to meet when the person happen to see or meet any one of the person, then that person become a susceptible person. So they have what we call a strength factor. So just ignore the symbols or the character BTA over N's. It's just a mathematical form to express the strength. How strength is the multiplication between the infected people and the susceptible people. Once the susceptible people met with the infected people, or met with the infected compartment, it becomes an exposed person. It is not yet infected, so that is why they have a 14 days period to monitor for several days. And now the susceptible compartment is a vulnerable compartment and is reducing number at the rate of minus BT over N. So again, just ignore the symbols there. And then the exposed person, the pink color now become ill, infected person. Whether or not you are in stage 1, stage 2, stage 3, 5, 4 to 5, you are now as infected person. So the infected person now meet another healthy person. So the healthy person now becomes the exposed person. Okay. So gradually, everyone now becomes infected. Gradually, everyone now become infected, and this would be the whole scenario of the whole compartmental model, whereby we have S, E, I, and R. Okay, and we do have a 10 to 14 days period, which is the period of the incubation for the infected people. And the infected people, if he or she is lucky, then he will recover. And if it is unfortunate, then it may cause death to that infected people. Okay. So this could be one of the things that we see normally during the presentations of our DG, where he said the infectivity, where he said about the infected people and the curve. Okay. Earlier, the COVID-19 can be modeled with SIR, but now we modify into SEIR. But when we look at the curve of the susceptible, the number of the susceptible people is reducing in terms of number, and the infectious people now inclining. The number of infected people is inclining and up to the maximum value. And now after the number is reducing for the infected people, we are now seeing that the blue color is increasing. The blue color is the recovered people or the removed people, whether or not they are died or recovered. So the R is increasing and the I is reducing. So where are the R naught? Okay, the R naught we're gonna see it later. So what I'm going to emphasize here, most of the time when the DG present, he did mention about the number of people who are currently infected or newly infected people. So the newly infected people is another aspect, but the infected people is the current number infected people, which is the people who are now undergone with 10 to 14 period incubation or 10 to 14 period isolation, 10 to 14 days period of isolation. So this is the full model, very mathematical. It's quite difficult to explain, but that's the whole scenario. Okay, and okay, this is the R naught. So what is R naught? R naught represents the reproduction number. R naught represents the production number. It is by definition, it is the number of cases on one case generates on average over the course of the infection period. It's a key of transmissibility and can be estimated in a number of ways from the data currently available. Or probably in other words, it is actually the number that represents how many of a single infected person that could infect other people. So the red color will infect the green color. So that would be the number represents by the R naught. Okay, so a higher number R naught would indicate that the outbreak could grow exponentially, and if the number falls down less than 1, it has an indication that the disease can be controlled and eventually died out. So why is it so important? Okay, initially the government they try to see the number of R naught to see whether or not the PKP under several phase is the strategy carried out by the government, it does work or not. So if R naught less than 1, that means the strategy carried out by the government, it does work. If it is not, then they have to probably modify the strategy under the PKP so that the R naught will be bring down to less than 1. So this is the whole process in order to calculate the R naught, whereby you need to calculate based on the rate of infectivity plus the rate here on the left bottom, the rate of infectivity plus the rate of the removed people divided by the rate of removed people. All right. So of course, when we are dealing about modeling, we need to have several assumptions. So this first assumption that we do is based on the behavior of the outbreak. So since it is actually the same virus coming from the China, so the behavior of the outbreak will be similar to China since December 2019. And we come up with a strategy which is to fit the model with nonlinear least square technique. It is actually a numerical technique from a mathematical point of view to the actual data from China and use that particular parameter to estimate the outbreak for Malaysian COVID-19 projection. And also in the model, we does not consider for any immigration rate or even any zoonotic cases, because the zoonotic cases was earlier detected in China. So when it comes to Malaysia, it is actually a infection between people to people. The estimation of the curve projection is based on the current infected numbers. It is the number of infected people officially registered in the World, because we got the data from Worldometer's COVID-19, and the objective of the projection is to estimate the possible number of active cases and the reproduction number, which is the R naught. And we also introduce another function or another mathematical derivation. We call it as a step function. Okay, so what is a step function? A step function is a function whereby we need to have a projection for several days ahead. Let's say for 10 days, let's say for 7 days, or even several months. We could do that, but the closest would be between 7 to 14 days. Okay. So this is the representation of the step function, the equation of the step function. Again, just ignore all these mathematical formulas. It could be very confusing, and even I myself sometimes confused with the formula. All right, this is an early estimation that we made in March 2020. Okay, the data that I'm going to show here is based on the projection of the first wave COVID-19, which is from March 2020 until September 2020. Okay, our early projection estimated that R naught was around 2.223, and the expected R naught was to be less than 1 is to be around early April, in mid-April 2020. Okay, so we do have a projection. We made a projection on March 2020, and it should be the case on the number of active cases around probably at the end of June 2020. And the bottom figure is showing the number of estimated R naught. Okay, and we do have the MCO1 and MCO2. Okay, the MCO1 is somewhere around early April, and the MCO2 is somewhere in mid-April. So the R naught is showing a reduction to have less than 1, to have less than 1 is between MCO1 and MCO2. And then our second projection is on 26th of March 2020. And we come up with another step function. And the red one is the actual data, and the blue one is the projection or the estimation. Okay, and the R naught is during that time it was around 1.7. And then we come up again with the second projection on the 5th of April, and again the R naught was estimated between 1.12. All right. On 9th of April, we do it is based on the projection on the 5th of April before. We update the data on the 9th of April. So the estimated projection was very close to the actual number of the current active cases. And the R naught on the 9th of April was 1.03. It was reduced from 1.12 to 1.03. Yeah. So from 5th of April to 9th of April, the number of R naught is reducing. So this is the projection that we made, and we made a comparison with MIR on the 23rd of April 2020. So MIR was the green line, and our projection the blue line, and this is based on the number of new cases daily. Yeah. So you got to remember that we have there is a difference between number of new cases daily and number of active cases. Number of new cases daily is the number of newly infected disease for every single day. But the active cases is the currently people under quarantine. And then we come up with this of update projection on the 14th of April 2020. On the 14th of April 2020, we have a very close approximation between the projection and the actual number of active cases. And during that time, the R0 was 0.84. So now we know that the strategy carried out by the government during the MCO1 or during the MCO2 has been it does work with the current strategy during that time. Okay. So the value of R0 begin to fall less than 1 on the 7th of April in year 2020. Again, we make a comparison again with the MIA. Our projection based on number of daily newly infected cases is in line with the actual data. And then we make a full probable projection somewhere in mid 2020. Our estimation of the first pandemic wave in our cases could fall almost 0 for current active cases. Is somewhere between 15th of July until early, if I'm not mistaken, somewhere early of August. Yeah. So that is based on full projection, and we come up with the worst case, and we come up with the best case, and we come up with the normal case. Okay. So this is another analysis that we made based on beta T, which is the rapid test estimation. The rapid test estimation is the estimation whereby we need to have an active rapid test carried out by the government, so that we know that so that we can know whether or not people who get infected in a quick way or in a slow way. So we need to have a rapid test parameter. So the rapid test parameter was carried out first by the China government, and then Malaysia tried to follow the same technique by imposing the MCO1 and the MCO2. So these are some of the parameters that we collected and we estimated during the projection of the first wave pandemic. And then we update the data for the whole projection. And this is the update on the 25th of April 2020. The number of active cases was around 1,800. And this is the full projection versus the estimation for the first wave COVID-19 pandemic in Malaysia. So our projection was quite close to the actual current active cases that we collected the data from the Worldometer coronavirus. And the R0 during that time, we estimated that the R0 was around 0.5. Okay, this is the highlight that I would like to say something here. This is the data that has been collected by the joint mission from the China government and the WHO. The report can be found on WHO China Joint Mission Coronavirus Disease 2019 COVID-19 report. We can download the report from the internet. Just type the keyword there, Joint Mission WHO and China. So we could download the data, and this is the data that is showing some. The data is showing that the date of report or the official report that has been collected by the China government was actually is actually a late report based on the date of onset. The date of onset, which is the date of the confirmed infected people when they got the first disease. But then when they go to the hospital, probably 7 days to 10 days after, so the disease was within their body for quite some time. Okay, so what I'm trying to stress here, what I'm trying to say is that the number of actual report cases was actually before that was actually the it's actually a late report. It's about 10 to 14 days late report. But we do not know whether the report that we do have here in Malaysia is based on the late report or based on the current report. So this could be one of the reasons that it's very difficult for the Malaysian government to control the disease, and the number of R0 is keep increasing. So in summary, the probable projection with the SEIR model can be achieved with several conditions: the government enforcement on the MCO movement and the other measure. Number 2 is we need to have an early detection technique and a good isolation strategy. And the third one is we need to have a good cooperation from the public, and so that the R0 can be bring down to have less than 1. So these are some of the references that we got. Our study is based on, and these are some of the conferences and the award that we got based on the research. So that's all. Thank you, Dr. Lokman.
Thank you very much. That was quite enlightening and different talk that we usually had. I really enjoyed that personally. So I open up at least for one question to Associate Professor Dr. Ramizi from the floor. If there is any. I saw that there is a hand raised by Liana Iksan, but I might have missed that. That could be for the previous presenters. But are there any other questions from the floor? Kalau tak ada, tak apa. But then again, I myself intrigued lah. I mean, is this model been applied? I mean, have you shown this model to the authorities, like macam orang-orang yang terlibat directly with regards to the, like the numbers that we see every day on the news?
Yeah.
Does this model been applied officially to predict those numbers lah? I mean, not predict the numbers, predict the outcomes.
Yeah, the number presented by the KMM, the Kementerian Kesihatan, was very close to our numbers, but we do not know whether they are using the same model or not. Okay, but as far as I know, SEIR model is the common model that been used worldwide. Even the UK, they're using the same SEIR model.
All right. Okay. So that's coming from that, I thought they were using this model already, applying this model, but since you said that it must be sure, so it is quite surprising in that sense. So with that, thank you very much, Associate Professor Dr. Ramzi, for your enlightening presentation, and it was very my part lah. I rasa macam benda sangat baru for me. I thought it was interesting. Okay, so we move on to the next presenter of the day. But unfortunately, this presenter couldn't make it to our session. Is that correct, Mr. Encik Khairi? However, the presenter will be presenting his a pre-recorded video. Please welcome to the screen the Associate Professor, Dr. Ramalingam Rajamanikam, to deliver his presentation on the guideline or panduan dalam pengendalian bedah siasat mayat semasa penularan wabak penyakit berjangkit di Malaysia, satu kajian kes tentang COVID-19. With all due respect, please welcome. Let's play the video that was given to us earlier. Yeah.
Hi, my name is Ramalingam Rajamanikam. I am an academician in the Faculty of Law, University Kebangsaan, Malaysia. Today, I would like to share about guidelines in conducting a post-mortem examination during the spread of infectious disease in Malaysia, a case study on COVID-19. The recent hike in the number and fatalities of COVID-19 cases has brought about discussion throughout the forensic pathology community and raised numerous concerns and consideration in regard to the examination of the disease during the pandemic. As much as an autopsy could benefit in providing knowledge on an emerging disorder, it also poses a great risk to healthcare staff who may contract the deadly virus while completing the examination. Improvised procedures and guidelines are necessary for management of the death within the existing regulation, which include post-mortem procedures. Post-mortem is an important process to determine the cause of death. Post-mortem is a Latin term for after death. In English, post-mortem refers to an examination, investigation, or process that takes place after death. There is no legal definition of what constitutes a post-mortem examination. According to the guideline set by the Ministry of Health Malaysia, post-mortem means an inspection carried out by the government medical officer on the dead body. This inspection involves internal and external examination to determine the cause and manner of death, or how the changes produced by the disease, chemical, radiation, accident, injuries, etc. The main goal of the post-mortem is to answer questions that arise about how and why an individual may die. The post-mortem examination are normally categorized into two types. The first one is clinical post-mortem, and the second one is medico-legal post-mortem, or known as forensic post-mortem. Post-mortem examination of both these categories are performed by a qualified government medical officer with different level of expertise. No post-mortem can be conducted by the private hospital. It can only be conducted by the government medical officers. Post-mortem also serves as an important component in the legal system, particularly in the criminal justice system. From the legal perspective, post-mortem examination is conducted to identify the cause and the manner of death. The post-mortem involved in this aspect is known as forensic post-mortem examination or medico-legal post-mortem examination. The leading agency in an inquiry into is the Royal Malaysian Police. The relevant law in this context is Criminal Procedure Code, CPC. In the Criminal Procedure Code, there are few relevant provisions. Section 329 of the Criminal Procedure Code states that the police are bound by law to investigate all sudden deaths reports, including homicide, suicide, and accidental deaths. Meanwhile, Section 330 of CPC provides that police would then arrange for a post-mortem examination to be conducted. And Section 331 of the CPC states that the mandate to conduct a post-mortem examination of a body is given to a government medical officer, which includes a forensic pathologist. No private hospitals can conduct post-mortem examination. Medico-legal post-mortem will be conducted only if the autopsy application form requesting post-mortem examination on body, which is known as Police Form 61, received by the medical officer in charge of the department or unit of forensic medicine in assisting the police investigation. Besides CPC, Another relevant law during this pandemic COVID-19 is the Prevention and Control of the Infectious Disease Act 1988, Act 342. According to Section 16 and Section 17 of Act 342, the investigation of a death in relation to an infectious disease would be considered under the jurisdiction of a public health officer, including the recommendation of examination of the death. These two laws are very important when we discuss pertaining to COVID-19 and post-mortem examination. Post-mortem also serves as an important component in the legal system, particularly in the criminal justice system. From the legal perspective, post-mortem examination is conducted to identify the cause and the manner of death. The post-mortem involved in this aspect is known as forensic post-mortem examination or medico-legal post-mortem examination. The leading agency in an inquiry into death in Malaysia is the Royal Malaysian Police. The relevant law in this context is Criminal Procedure Code, CPC. In the Criminal Procedure Code, there are few relevant provisions. Section 329 of the Criminal Procedure Code states that the police are bound by law to investigate all sudden deaths reports, including homicide, suicide, and accidental deaths. Meanwhile, Section 330 of CPC provides that police would then arrange for a post-mortem examination to be conducted. And Section 331 of the CPC states that the mandate to conduct a post-mortem examination of a body is given to a government medical officer, which includes a forensic pathologist. No private hospitals can conduct post-mortem examination. Medico-legal post-mortem will be conducted only if the autopsy application form requesting post-mortem examination on body, which is known as Police Form 61, received by the medical officer in charge of the department or unit of forensic medicine in assisting the police investigation. Besides CPC, another relevant law during this pandemic COVID-19 is the Prevention and Control of the Infectious Disease Act 1988, Act 342. According to Section 16 and Section 17 of Act 342, the investigation of a death in relation to an infectious disease would be considered under the jurisdiction of a public health officer, including the recommendation of examination of the death. These two laws are very important when we discuss pertaining to COVID-19 and post-mortem examination. In terms of comparison, the Ministry of Health and Family Welfare in India has strictly suggested to avoid autopsy to be conducted in any COVID-19 dead bodies. However, if the confirmed COVID-19 case is registered as a medico-legal matter, meaning that a forensic matter, the medical practitioner is required by law to notify the investigating authority, and the decision whether an autopsy should be performed is at the discretion of the investigating authority in accordance with the statutory laws while keeping the general interest of the community in mind. Whereas the UK approach in this context is very similar to that of India. In UK, if a person's death is thought to be the result of confirmed COVID-19 infection, an autopsy is unlikely to be required, and a medical certificate of cause of death should be issued. However, if the infection is involved with a forensic case, which is also known as a medical legal case, then the legal duty impels a proper and appropriate autopsy to be conducted. This is the position in India and UK. The pandemic of COVID-19 has caused many problems and challenges, including to the criminal justice system, particularly in conducting post-mortem examination to determine the cause of death. Determination of cause of death is significant as it informs us about why a person died. And these cause of death become very significant in cases involving legal issues. For example, to determine whether it is homicidal or suicidal, or to determine whether this is homicidal or accidental. In the current situation, post-mortem is not conducted in all kinds of deaths to serve the criminal justice system when the result of COVID-19 test is positive. We cannot deny the fact that there may be instances where the result of the COVID-19 is positive, but the person died not due to COVID-19, but due to criminal act of other person. In this context, law must provide clear guidelines to all the players in the post-mortem examination, particularly the medical officers and the police. Medical officers and the police are two important components in the post-mortem examination. The medical officers are the person who perform the post-mortem, whereas the police officer is the person who determine whether the post-mortem is required or not in accordance to the law, because they are given the power to decide whether the post-mortem is needed or not. Therefore, law needs to be improved from time to time to fulfill the current needs of the country and the justice system. With that, thank you very much and good luck.
So that was actually quite good in that sense. There are different aspects of medical, legal aspects of handling COVID-19. Not patients, but in terms of handling COVID-19. It's unfortunate that we don't have the associate professor with us, otherwise we could have more questions coming from him, more Q&A sessions with him. Now, with that, I'm going to continue with our last speaker of the day. Okay, certainly not the least. I would like to welcome to the floor Dr. Muhammad Ramzan Buyong, the current Deputy Director for Center for Innovation and Technology Transfer Innovasi at UKM. Our speaker has had 16 years worth of experience in micro nanofabrication technology and has filed more than 25 patents in his field of research. He focuses on MEMS or NEMS micro nanofluidics, specifically in dielectrophoresis in micro nanofluidic technology. Now, without further ado, please welcome our speaker with his presentation, Inovasi at UKM Berstruktur, PRL Technology Readiness Level, Pengkomersialan, Penyelidikan dan Usahawanan, sesuatu yang perlu kita terokai. Please welcome our esteemed speaker, Dr. Muhammad Ramzan, to the floor.
Bismillahirrahmanirrahim.
Hello, Assalamualaikum.
Assalamualaikum warahmatullahi wabarakatuh and very good morning. So, dah boleh nampak ke slide saya?
Belum lagi.
Okay.
Alright, good.
Okay, Alhamdulillah. Terima kasih. Okay, kepada Dr. Muhammad Rahman. So, my name is Muhammad Ramzan. So, my topic is quite different also from others panelists. But however, it will help you how you want to migrate all the research in the lab, how the policy that we make into the product or service that we can deliver to the community or the impact. So today, I will share with you, I hope it's not one way, we can do a two-way communication, which is I just present the data already or the guideline already available in the MOSTI, MOHI or Inovasi. So today, this presentation describes briefly the structures of innovation based on TRL scales. So the TRL scales means that the technology readiness levels. So means that once we did research, is ready or not to be commercialized or what? Okay, so which including some example adaptation to MOHI, MOSTI, and Innovasi funding schemes. So this presentation also suggests the possible way to look further adaptation of this TRL scale to best fit of innovation or Innovasi at UKM programs. So next. So we know about the innovation cycle. We have a first wave, a second wave, third wave, and so on. However, how does innovation can be structured? Okay, means that they have a various method of if you want to evaluate the innovation that we make in the lab or research in the lab. But this is one of a common method. I call it, we call it as a technology readiness levels. So this is one of the TRAS action item, which is based on the IMINDA and Innovasi, which is it will help of penaikan taraf produk, padanan perniagaan, suntikan dana, penghasilan prototype dan perkomersialan. Okay, so as we understand, we have two types of research, which is a basic research and applied research. Which is a basic research is a drive based on curiosity driven. Like for the common case now is based on the COVID issue. But somehow this research need to be translated, need to be transformed to one's commercialization or activity that we can deliver to the community. So somehow we currently at university, we play with the knowledge economy, means that we don't commercialize further what we are doing in the lab. So I would like to discuss about TRL. You can find a lot of definition of TRL in the web. So it's quite common for engineering people, okay, especially from medical people, if they want to do a device or test kit, whatever, so on. So university at UKM are very active in innovation and commercialization program. In this capacity, we have identified and increased the use of TRL level at MOHI, MOSTI as a planning tool for innovation and commercialization management. Accordingly, university at UKM feel that TRL scale should be better understand to allow its efficient use in the further planning, innovation and commercialization program, not just associate funding program. In this context, the aims of this presentation to offer UKM researchers, scientists to understanding of this scale. Research, innovation and commercialization program are active throughout this scale and leads the project in the TRL area in a way of collaboration with the industry at the higher level and then the academia at the lower level. So in a simple word, in the layman term, means that TRL help us to identify the maturity of the research or technology that we develop in the lab, either in the faculty engineering or medical. So I'm not sure about this. I think it's quite common as I refer to the web that have been used. This method even has been discussed into the Parliament Scotland, which is for medical device, they have a 3 type of TRL, which is they do basic and applied research, translational development, and clinical and regulatory approval. So it means that once you have developed the kit, everything's in the lab or wherever so on, we need to go through all these steps to make sure that our product has been certified or qualified. And then we can become we can do the commercialization process. So I hope it's not just one way. I think I have my presentation is very short, but if you have any question, can ask me further. So overall, the summarize of the structure, okay, inovasi at KM we call is the place is under the cream. We manage all the IP and the commercialization process. So we define it as a structured innovation at UKM. So this is important to understand of this TRL because all the research and innovation management, funding, reviewer tool, and collaboration selection, the most important thing, decision-making process for research, innovation, and commercialization format. So this is one of the example of the standard where we're going to do what's next after the research in the lab. So if you refer more here, I'm not sure people in the medical faculty, but for engineering people like Fakulti Kejuruteraan, we understand, we need to understand all these TRL. Means that somehow the research where in the lab or we do the field test or validation, and then somehow the TRL 8 and 9, we need to have a complete and qualified. So basically, to simplify, I will share this information. They have different definitions. It's not different definition, it's a summarize. So means that the first TRL 1 and 2, we need to complete the principle and formulated on the paper. And then we have a proof concept in the lab. Okay, so means that TRL 1, 2 to 4 that normally we do. After we do the research, we're finding the result and we file the patent. But somehow moving forward, we need to have this technology validated and demonstrated for field tests. Means that it's not just you test the COVID, you take from the sample from other people, but we need directly to test at the field test. Means that, like say, if you do it COVID-19 test kit, then you say that they're capable to detect the virus through the saliva in the lab, but somehow we need to send this technology to community. So means that we validated and demonstrated in the field test. And finally, this is most important thing. Okay, means that once we go into the lab and the field test, we need to do the qualification or certification test. So means that it's not just research in the lab or the field test, but there's somebody to certify of this research. For common, I think for medical research is more to Malaysia, we have MDA or FDA or whatever so on. So I think it's quite common. I think we can see all the medical faculty member manage to get all the PRJS 1.0. So it means that when we apply these grants, so the prototype research grant scheme means that our work must in this loop, means that when you apply this grant, the work activity or the milestone is experimental proof of concept, lab validation and validation in the environment. And I think 2020, last year, MOHI also offered the PRJS 2.0, which is the TRL is a quite high, which is including the validation in the real environment, demonstration in the real environment, and demonstration of the prototype. So another agency that use this standard, we know is the MOSTI. After the MOHI, normally we apply grant for the MOSTI. As we can see, they have a different definition, but somehow the content is somehow in the lab experiment and then the field test and certification. So we can see the different type of research. We have a basic fundamental feasibility study, which consists of TRL 1 to 4, and then innovation for further innovation of product development is somehow is called applied development TRL 4 to 6, and then demonstration TRL 6 to 8, and operational deployment means that TRL 8 to 9. So in other way, we simplify it, is a proof of concept TRL 1 to 4, alpha prototype 4 to 6, beta 6 to 8, and then the minimum product viable 8 to 9. Okay, previously we did the research, we do the research, and then we do some field tests, and then always that miss in our level is the certification and qualification, means that the higher TRL 8 and 9. All data available in the innovasi, which is all the patent is just put on the shelf. Okay, means that TRL 1 and 4 is a lot of patent file, copyright, everything. But we have, as request by MOHI and KPT, we need to deliver because we are spent a lot of patenting. We need to transform all on-shelf IP into the community. So this is a quite common information, but this is a way that we need to move forward. Okay, so POC and then alpha, beta, and MVP. So this scale, okay, there are a lot of members, which is when they want to apply their grant, they come to the innovasi at KM to confirm their TRL. So means that by doing this presentation, all the researcher, all the scientists, all the clinical should have some kind of this idea of the TRL. So what we do at University UKM, we want to help all the researchers, the scientists to move their research in the lab to the higher TRL, means that 6, 7, and 8. Okay, in fact, our innovasi also offer the internal research funds, which is a pre-commercialization fund. We call it a Dana Innovasi, which is we play a role in the wide bandwidth of TRL. We play TRL 4 to 8, and then which is Dana Innovasi is capped to 100,000, and lab to market, which is 250,000. Okay. All right. So I think this is my last page. Okay. The most important thing, innovasi at UKM hope this short brief demonstrates clearly that warga UKM of AFPER have clear role in translating research across the entire TRL in cooperation with existing and emerging industry and academia. So this is we talk about the from idea to the application. Once of the guideline is structured innovation. With that, I end my presentation. Thank you.
Thank you very much, Dr. Muhammad Ramzan, for the talk. I open to the floor. You know, this is the best time for you to ask questions. I mean, maybe you're not from UKM even, but it is something that is Dr. Muhammad Ramzan is well versed about in terms of TRLs. Are there anyone who would like to personally ask questions on the matter? Hold on.
Assalamualaikum. Saya
Waalaikumsalam.
lagi. Okay.
Yes, please.
Saya nak tanya Dr. Muhammad Ramzan. If let's say we have a device, a medical device, and we haven't got the certification from MDA, it is categorized under TRL 7 or TRL 8?
Okay, Prof. Maybe I need to have some information. Is that we have gone through the field test, means that it's out from the lab, and then we have some data of the field test. Because when we want to do the certification, MDA or FDA, we should have some previous work data. Do we have some field test data, Prof?
Yeah, the field test too, for example, is entry in the market study, right? Or the test done by SIRIM or by by some bodies like serum or the other one is I forgot. So that one is mean the field test, is it?
If proceed, the serum test is a one of example of certification process. So means that you are in the TRL 8. Yeah.
Okay, thanks, doctor. So the another question is the PGRS 2.0. How much is the ceiling?
2.0, I think is the cap is about 1 million, bro. And then mereka offer last year saja. I'm not sure about this year. And then from UKM, I think we have 3 successful. Okay, they managed to got 650, 150, and 75K. So that's why even though PRJS 2.0,
yes.
Boleh nampak slide saya ke tak atau macam mana?
Nampak.
Okay, so PRJS 2.0 dia yang penting sebenarnya apabila kita mohon PRJS ni, dia mesti jatuh dalam the work, the milestone is adakah dia validation in the real environment, demonstration prototype is a complete system. So katakan about yang kenapa dia boleh dapat hampir 500 plus sebab kerja dia melibatkan TRL 5, 6 dan 7. So kenapa dia dapat TRL 5? Why they managed to get 75K? Because the scope or the milestone just in the TRL 5.
Okay, thank you, Doctor.
Okay, terima kasih, Prof.
All right, Dr. Ramzan, this is coming from me lah. I'm a new lecturer. I'm charting my path, and sometimes the thought of the business pipeline along the way can be quite challenging lah. So can you tell us a bit about the pipeline itself? Like what you're showing here. How long does it take to usually from bench side to actually market like the product? And then and if you don't mind, if you have the figures. Boleh tak nak tahu berapa ramai orang yang at least from the Faculty of Medicine that applied through the internal grants offered by K University, and how many have succeeded and how many have actually produced those products by K University, if you have those figures lah. So at least just to give an idea kan, of young researchers yang rasa macam okay, this is an avenue where they can focus on along the line. So it's not just basic lab research, but something to like commercial and make money. Okay. Berapa lama tu sebenarnya commercialization process is sukar, memang quite tough. Memang dia banyak cabaran dalam kita sebab because we are researcher, we are scientists. What we want to do is about to solve community problem, but somehow when we do the marketing, when we do the commercialization, they have some business people in their mind to strategize the technology. Okay, but what I can say, we have Prof Yazid, I think Prof Yazid Yazid do the kaki palsu tu kan, yang daripada positif. So dia do, itu one of the example yang manage to get the dana inovasi dan dana-dana yang lain kerana pendidikan beliau, okay, bermaksudnya dia menyelesaikan masalah komuniti dan benda pendidikan tu dia minimum viable products, bermaksud dia boleh nampak on the physical. So means that all the mechanical issue, dan kemudian dia telah memberi pengujian di makmal beliau sendiri di semasa diorang memberikan rawatan, dan beliau mempunyai data. The most important thing, apabila kita nak menjual sesuatu benda tu, dia mempunyai data yang lengkap dan menyelesaikan masalah lah. Itu secara ringkas lah.
And then in fact kita ada lab to market Prof. Ruzima, which is yang mengenai lututku. Okay, so sebenarnya teknologi itu dah ada di Fakulti Perubatan, tetapi dia harus mengikuti all this kind of the process, means that in term of, let's say, a proof of concept already in the lab, technology refined, and the most important thing, they do the trial to the patient. It's not in the lab sample. Then we can upgrade the scale from 5 to 6, and then finally kita boleh buat TRL 8 di mana kita buat certification. They have one body to certify. Okay, this is okay. This is good. Okay, it's not just to the lab level of the clinical. I think I believe, but all that technology already in the medical faculty, but somehow we need. That's why we said that kita perlu membawa dia kepada masyarakat clinical and human trial dan certified. Is that menjawab?
Yeah, exactly. I agree with that. Yeah. So we have one participant who's raising her hands here, Aniza Hamizan. Is there anything? Oh, okay. So that was not okay. So, anyways, are there any more questions from the floor? I mean, this is your chance. If you have any ideas, you know, Dr. Muhammad about Dr. Ramzan here would help you greatly. Anyone, any students who are maybe starting in their masters, yang mungkin in the long run would be interested to get whatever you guys are studying to get it published. This would be the best time for you to you know, get yourself pointing you to the right direction lah, in that sense.
So jika terdapat student lah, sebenarnya saya we are inovasi educate and memang menggalakkan. Somehow this research TRL ini membantu untuk kita drive direction of the research. Means that we have the formulation, and then what's next? Okay, then we do the lab validation and validation the environment and demonstration, which is a very straightforward and guideline.
Yes, that is quite clear. All right, so if that is the case, then maybe we have to we cut short lah with our talk today. Thank you very much, Dr. Muhammad Ramzan, for your time and explaining the opportunities lah that will be possible for us, and not just on basic sciences, but actually commercializing the stuff that we have found in the lab. And obviously, in the case for COVID-19, I'm sure there's a lot of innovation that can be applied either through diagnostics or any other fields of you know, research lah that would help to apa kata memantapkan lagi atau menyenangkan lagi lah. Then again, our money is also the public's money, so this is where our research would actually help them to see orang kata secara orang kata nampak lah, kita nampak benda tu berhasil, dan these people would benefit from that. So thank you once again, Dr. Muhammad Ramzan, for his presentation. I appreciate that. So now, ladies and gentlemen, with that, we end our symposium, COVID-19 symposium. Okay, and on behalf of the committee, we hope that you enjoyed and benefited greatly from the various exceptional presentations that were delivered by our esteemed lineup. We also hope that you have benefited greatly, especially for the students or for those who are actively participating throughout the research week, through the modules. Hopefully you get, I mean, you've learned something, so it's not just something that you just attend. And we humbly invite you, before I end the session, we humbly invite you to join us for a special session scheduled this Friday, a morning coffee talk with our distinguished professors with the theme of the art of publishing in the top 10% journal. Okay, so on behalf of the Medicine and Health Committee, we thank you again for participating this year's program. We pray that you fared well in your research journey up ahead. All the best in your future endeavors. Stay safe. And thank you once again to all the presenters here for coming, for presenting your time and whatnot, your time and your energy to actually present your stuff. I'm Dr. Muhammad Luman, signing off for this year's Medicine and Health Research Week. Have a pleasant day, everyone. Assalamualaikum warahmatullahi wabarakatuh. So you may now enter, Dr. Encik Khaide will provide you with the CPD points and feedback form. So please do, we need to hear some feedback for us to improve for next year's events. So whether it's good or bad, we welcome them with open hands. So thank you once again for everyone. Yeah, have a good one. For those who are still here, please be reminded, for those who participated for tomorrow's poster presentation, the event will be, hold on. The event will start at 9 a.m. And going through into 2 different categories. So those involved in clinical and preclinical categories. Okay, thank you very much.